Good morning, everyone. Good morning, my friends, colleagues, and most precious endometriosis patients all over the world. Some of you, I have to say good afternoon, certainly. We have more than 1,600 registrants to our 13th annual medical conference and patient day. We made it a little bit different this time. We claimed the whole month of endometriosis awareness month for the weekends. It's like a weekend marathon. We claim these Sundays to be with you. Today's lecture and the focus is peritoneal endometriosis, the most ignored, the least known, most challenging part of endometriosis care, cause of the delay, everything that's been misunderstood about endometriosis. But most importantly, I wish I could connect to you in the most in a better circumstances, to be honest with you. We thought COVID was over. Now a cruel war is raging in Ukraine. Many women, children are homeless. They're separating from their fathers, loved ones. It's hard, but it's chilly morning in New York City. It's very cold inside, and we bother to be with you. We have to do our work. Life goes on. I will introduce our very prominent medical director, Dr. Dan Martin, to start the conference. Dan, take it.
Okay, thank you, Tamer. It's a pleasure to be with you today. I look forward to the presentations and comments and hope that this will be an enjoyable and productive meeting for you in the audience. The first presentation will be mine on what patients need to know for their daughters and what patients need to know, what parents need to know for their daughters and what patients need to know for their siblings. We'll start that presentation now. It's a pleasure to be with you today. I'm glad to present a presentation on what you should tell your daughters. This is also for the daughters and sisters and what they need to know. The goals of this presentation are to help you reject the normalization of pain. Remember, killer cramps are not normal. We need to encourage proactive care and planning so that you know what's going to happen if the pain doesn't get better. We will consider hormonal suppression because it can decrease estrogen stimulation, can decrease activation of cells of origin, and can decrease the growth of endometriosis. Also, non-steroidal anti-inflammatory drugs such as ibuprofen and holistic care can also decrease inflammation, activation, and growth. One of the reasons we're doing this is because of the prevalence that shows up in genetic studies. One caveat about genetic studies is that the prevalence in genetic studies is generally less than the prevalence in epidemiologic studies. Exactly why that is has to do with the way the studies are done, but it's an observation. We can generally see 1 to 3% prevalence in control groups in genetic studies, 10%, which is the number you're used to, in epidemiologic studies of diagnosed endometriosis. And if we look at all endometriosis that's potentially diagnosable, that includes incidental endometriosis, endometriosis found at the time of tubal ligations and others, the true prevalence is probably closer to 28%. All those numbers are compatible. They are not conflicting. They are just different ways of looking at the same studies. But you need to be aware of that 1 to 3% for some of the slides I'm going to show shortly. If we look at the inheritance is easiest to see in identical twins. The concordance in those identical twins is almost 80%. That means that if one twin has it, the other twin has about an 80% chance of having it. But when you look at first-degree relatives such as mothers and sisters, the prevalence is much lower. It's closer to 4.3 to 6.9%. Note that the control groups are running between 0.6 and 2%. And that first one, that 0.9 to 6.9, means that there's 7 times as many first-degree relatives as there are controls. So when you hear this 4 to 7% figure, or 4 to 7 times figure, that's what they're talking about. And we're going to come back to that in a while. More recently, Naruzzi did another study which showed that there was about a 3% instance in his control group, in their control group, compared to 5.9% in the endometriosis group. When you summarize all of those, the total risk in genetic studies is around 4.3 to 6.9%. That represents a 2 to 7 point fold increased occurrence, or an absolute risk of about 2.9 to 6%. All of those say the same thing, looking at it from different angles. If we look at the epidemiologic studies, that represents about a 50% increase over the 10% prevalence, or about a 15% total. Remember, when we talk about a 50% increase of 10%, that's not 50% of everybody, that's 50% of 10%, or 5% total increase for that group. There are lots of general concerns that adults and teenagers have. Among those are the normalization of pain. Teenagers and adults can both be ignored, dismissed, or marginalized in the office. For teenagers, it is harder for them to sometimes let their voice be heard than it is for adults who are more used to dealing with these kind of problems. Another significant problem is the lack of proactive plans. Patients are commonly told to come back if you need to. They're not given repeat dates. They're told that this should take care of itself. When we're taking care of severe pain, we need follow-up visits to make sure that ongoing plans are carried out. And the last problem is when we need hormonal suppression, which we'll use to decrease the stimulation activation of endometriosis, then for teenagers, there's much more concern about being on oral contraceptives than for adults. Teenagers' peers wonder what's going on. There's fear of being found out. There's fear of what their parents will think. But we need to get over that. And if you really need to stay away from oral contraceptives, there are other alternatives that can get the same thing done to treat the endometriosis activation and stimulation by using formulations of estrogen and progesterone that are not oral contraceptives. Then the two big conflicting concerns. The first is that delayed diagnosis may increase the extent of endometriosis. That's all based on retrospective data. There's no prospective data that shows that. And that early surgical diagnosis increases repeat surgery. We're going to review some of those. If we look at the repeat surgery first, then we know that based on lots of data that the reoperation rate decreases the older you are. And it goes from a 2-year reoperation rate at 80% to a 7-year reoperation rate of 15% when you're looking at those who are less than 18 and those that are more than 42. There are lots of reasons for that. If you look at those first two, but this is for the physicians, if you look at the first two, the major difference between Patrick Young and my data were that mine were based on dark scarred lesions and his are based on any abnormal peritoneum. So if you're a surgeon and you're in there operating, remember any abnormal peritoneum can be endometriosis using near contact laparoscopy. In Albie's study, that was about 25% of abnormal appearances, abnormal peritoneal appearances, not lesion size, not the phenotypes, but just an appearance of not normal, was associated with endometriosis. So if we go after any abnormal appearance, we may be able to decrease the recurrence rates in young women. That age-related decrease is related to the lesion size and color increasing with age. We're going to go through some of the small lesions and adult lesions. The lesions become easier to see. There are pregnancies in ages 20 to 30, and sometimes later, that have progesterone that can decrease activation, decrease the growth. And there's a perimenopausal decrease in estrogen in the 40s that decreases the stimulation. Remember, the life history of endometriosis is all endometriosis begins with the cell of origin and a method of dissemination. That is any theory you've heard, whether it is a retrograde menstruation, Mullerian rest, a bone marrow stem cell, peritoneum, they all have to have an original cell of origin that was normal and a way for it to get into an abnormal position. Then there's a stimulus of activation, and we'll go through the different stimuluses. And then there are other stimuluses that cause transition and growth. And lastly, for many women, the endometriosis can be inactivated and either stabilized or cleared. Activation is generally due to estrogen, inflammation, and failure of immunosurveillance. That is, estrogen causes cells to grow. Estrogen increases the inflammation in the area. Inflammation can be associated with estrogen or with infection or stress or retrograde menstruation, causing not the display of not only the transition of glands and stroma, but also iron, and the iron can form an inflammatory component. And then there's a failure of immunosurveillance, which means that the body, as we heard in earlier talks, the body does not clear the endometriosis the way it should, and it goes into a state that actually encourages the growth rather than discourages the growth. Note that those are not dependent on the cell of origin. They're not dependent on what you think the theory is. All of those happen whether you want to believe in retrograde menstruation, Mullerian rest, or any of the other theories. The cell of origin starts in a cell of origin starts in all of them. All of those tend to support the ACOG's conclusion in 2008 that if you have dysmenorrhea with a normal evaluation, the first two things to use are nonsteroidals and oral contraceptives or an equivalent estrogen-progesterone combination. See the patient back in 3 months, or if you are the patient, be seen back in 3 months. And if the pain is still present, the evaluation needs to be increased and extended. And some of those evaluations that happened have to do with rescheduled repeat examinations, uses of ultrasound, occasionally MRI, and if we can't find a way to stop the pain, then laparoscopy to look inside and see if it's endometriosis is finally indicated. Remember, all of this, we're talking about a time span of between 3 and 12 months. We're not talking about the 6 to 10 year delay that we're talking about in adults in terms of developing most of the problems they have. This is 3 to 6 months. This is a time span that is intentional, and we mean to do it, but to keep it held to that 3 to 12 months, we need to be proactive in being sure that it occurs. As a note, rectal exams can be more acceptable than vaginal exams. Many teenagers don't want to have vaginal exams. Many adults don't want to have vaginal exams. A rectal exam may be more acceptable, and that's both physical exams and ultrasounds. As an alternative, if neither rectal nor vaginal exam is acceptable, then abdominal ultrasounds and MRIs are available. When we look at most of what you've heard in the literature and on the websites and everything else, a lot of what you've seen is retrospective data. There's very little prospective data. There's one good study on prospective data out of Australia, which was Knox et al., who in 2019 reported on adolescents with dysmenorrhea. There were 70 of them, and they were treated proactively with nonsteroidals, oral contraceptives, scheduled visits, and ongoing evaluation. They had an average follow-up of 10.2 years. And what they noted in these groups with a prospective plan for treatment is that none developed more than mild endometriosis. And of the 70, 19% developed endometriosis. And of those who had laparoscopies, it was 54%. A comparative group in adults in Frank Ling's study, when treating with nonsteroidals and oral contraceptives, Frank actually used nonsteroidals and GnRH, and Jenkins used nonsteroidals and oral contraceptives and got the same data. In their groups, it was 82% of the laparoscopies. So in adults, those numbers were higher. So it looks like NOx, compared to adults, is holding down the number and holding down the stage. Looking at asymptomatic endometriosis, that's a different group. Remember we talked about the ones where we get up to 28%? We can actually get numbers higher than that if you look at subset groups. But of that 2 to 43% prevalence that were reviewed, the overall average for that is about 16% of tubal ligation patients who are asymptomatic will have endometriosis. And when those patients are followed for 12 to 14 years, there's no difference in their outcome. The finding of endometriosis when it's asymptomatic does not mean that anyone's going to have problems in the future. Doesn't mean that you can ignore it, but it just doesn't mean that something's absolutely going to happen. Some women are going to develop ongoing pain, whether they do or don't have endometriosis, and that requires ongoing evaluation. Interestingly enough, even rectovaginal nodules that are asymptomatic are stable or regressive in 93% of patients. So rectovaginal nodules have about a 6 to 7% chance that they will become symptomatic or grow. So you have to pay more attention to those. In addition to all of this, we've heard earlier talks about holistic care, alternative and complementary medicine, nutrition, stress management, all these others. All of those can help decrease the stressors that cause ongoing growth of endometriosis, and controlling all of those can be useful. Looking at the appearance, remember the adult appearance that most of us are generally used to looking at are these large lesions. If we look at the one on the left, that's a 3 by 4 centimeter area of endometriosis that has the bowel adherent to the back of the uterus. So almost 1.2 by 1.6 inches if you'd rather go to inches. But those are large nodules. Or you get these smaller diffuse nodules coming throughout the entire broad ligament. That entire area that starts out with these little yellow, this little blackish lesion here and going all the way through the ovary is infiltrated with endometriosis along this entire line. So all of this area, and what we did was resect the entire thing. And those aren't very deep, they're just diffuse. So it's only about 3 millimeters deep, but it's almost 5 centimeters wide. That is contrasted with the subtle lesions that occur in teenagers. In teenagers, they can be more like this. So instead of measuring things in centimeters, we don't even measure them in millimeters, we measure them in microns. So these 200 and 400 micron lesions, remember 200 microns is about 1/100th of an inch. So these are quite small. If we blow them up, you can see that this small 200 micron lesion is mostly a glandular lesion sitting within the peritoneum, does not even make it to the healthy loose connective tissue. And this little red polypoid lesion is sitting on top of the peritoneum, on top of the tissue, and it has both glands and stroma. More interesting is, since you can blow these things up after surgery, those are the smallest lesions we could see at surgery. But if we blow these up on a 35 millimeter film after surgery, we can see lesions as small as 80 microns. So we see very small lesions in there, which is one of the reasons that when we're operating, we don't go for just what we see in terms of specific lesions, but any place there's anything that looks abnormal, you can see all these little reddish blushes back in there. We'll come back to this reddish blush later because it turns brown sooner or later. But any place the peritoneum is not normal, all of these areas in through here, see these little brownish red blushes back through here. Any of those, we want to make sure that we either resect or coagulate to be sure that everything's treated. Since these are quite small, whether they're excised or coagulated, they tend to be easy to treat. Excision is probably better because you can get a tissue diagnosis. And the reason you need a tissue diagnosis is these subtle lesions also look like psammoma bodies, endosalpingiosis, nonspecific inclusions, hemangiomas, granulation tissue, low malignant potential tumor, and a lot of other diseases. We'll show you pictures of some of those later. Another area in a 14-year-old, a little 3 millimeter red polyp. These little red polyps tend to be hypervascular, lots of blood cells, lots of blood vessels in them that you can see in the H&E stain that has gland stroma, lots of blood cells. More important for this 14-year-old was not that lesion. That's just a good example of a red polypoid lesion. But she also had this in the right side of the pelvis. That's a 4 by 8 millimeter of what looks like old blood or something sitting on top of the peritoneum. In fact, that's stroma. I don't have a picture of her histology, but Tamer Second recently had a patient who, after an excision, about 5 years after an excision, had similar lesions growing in the resection pocket. And on that, you can see that the stroma on the right is sitting on top of the peritoneum. It's just loosely implanted, just very loosely attached to there, or very early attached. Loosely is not a good word. It's more early attached, and it has loose connective tissue beneath it. So this is just early attachment, early stromal lesions. And those may be some of the earliest changes. For the physicians, remember, that's all it looks like. Doesn't look like much of anything. If the peritoneum doesn't look normal, it might be endometriosis. In this one, different sort of area for that abnormal peritoneum, we can see 1 millimeter clear vesicles. That's, remember, a millimeter is about 400th of an inch, in that brown peritoneum. Of interest, the vesicle, the little clear thing, is the endometriosis. The brown peritoneum is iron from where remember, blood is iron-based. Hemosiderin, which is in blood, is an iron-based compound. So this is just the iron that comes in after the blood from bleeding is resorbed, and it gets implanted in the peritoneum. And if we look at those under microscopes, on that top picture is an H&E stain of hematoxin and eosin that shows the glands and stroma, but doesn't demonstrate the iron very well. The lower slides are similar pictures with a Mallory iron stain that shows how much iron is incorporated into those slides. Those brown areas of the peritoneum are the bottom one on the right, where the iron just goes through the entire peritoneum and lights the whole area up. These little lesions are little inflammatory lesions. They're either early endometriosis with stromal cells or inflammatory lesions that precede endometriosis. So we don't know if this is a slide that shows early endometriosis, because there's no glands in stroma, and the stroma would be lost because of the inflammation. You'd have to do CD10s, and this was back in the day when we weren't doing CD10, so we don't know if they're CD10 positive or not. But if they're CD10 positive, then this is endometriosis that's preceding glandular formation. Or if it's not, this is the inflammation that causes induction of endometriosis, either because it gives a landing spot for retrograde menstruation, or it causes metaplasia of the peritoneum. This lady did have endometriosis found in subsequent surgeries. We do need histology to determine the pathology, and sometimes that has to include CD10s to make sure whether it is or isn't endometriosis. A major reason that we need histology is because of all the look-alike lesions that can look like everything we just named. And we're not going to review those individually right now, but those can all look like endometriosis. As examples, all 6 of these are not endometriosis. There's no endometriosis in any of those pictures, in spite of the fact that some of them have been called endometriosis by physicians before they were sent to me. But those are examples of endosalpingiosis, psammoma bodies, low malignant potential tumor, altered rest, inflammatory inclusions, and hemangiomas. In conclusion, killer cramps are not normal. You need to reject the normalization of pain. Remember, pain needs to be treated. We need coactive care and planning to include plans for exams, imaging, and possibly surgery. But if you can go asymptomatic, you can avoid surgery. If you do try to avoid surgery, remember that if you're asymptomatic and it looks like everything's okay, you still need exams at least every 6 months or a year to include possible imaging to make sure that there's not something growing that you don't find. Use hormonal suppression unless you plan to get pregnant to potentially decrease the activation and growth. And non-steroidal anti-inflammatory agents and holistic care are used to decrease inflammation also. If you can decrease inflammation, you can decrease activation and growth. There are lots of resources for this that are at danmartinmd.com. My contact information there. There's a links page that goes to the atlases that all those slides came from. And for those of you who are interested in concepts and theories, that file is now up to 560 or so references. So if you want to do an in-depth dive into concepts and theories, that's a good file. Thank you. I hope that was a useful presentation. I would like to introduce Neve and Lane Raycan. They will share their story of living with endometriosis as twins.
Hi, my name is Neve.
And I'm Lane.
And we are 22-year-old twins, if you can't tell, that live in New York, and we both have endometriosis. So to start our story, we got our period at around 11, and we both had really painful, really heavy periods from the first time we got them. And it was kind of normalized in our household that painful periods was normal. I remember I used to feel kind of guilty for asking if I could skip school because I thought everyone's periods were that painful. And then specifically for me growing up, I was diagnosed with IBS. I had really any problem to do with, like, I thought it was food-based, and then I went from all these different diets and just really painful bowel problems. And then Lane had really frequent urination. I used to joke that she was like a pregnant woman in terms of having to go to the restroom all the time, which ended up being connected to our endo, as well as we both just had really painful intercourse and just overall inflammation in our bodies a lot, like the endo belly with the just. We thought it was just normal to be really bloated every time we ate or all the time. So anyways.
Yeah, so I started to seek treatment during my first year of university because the pain kind of became debilitating and I wasn't able to go to school. So my OBGYN was the one that brought up possibly having endo. We have a family history of endo because our mom had it, but for some reason we hadn't really connected that we also could have it because it was just so normalized to have such painful periods. So we were finally diagnosed after in our second year of university, and then we had our surgery last February. So we had deep excision laparoscopy surgery in New York City, and immediately we felt relief. Between the two of us, they found about 80 lesions across our bowels, rectum. On me, it was across my bladder. And since then, I think the biggest relief for us was our digestive issues have really gone down completely, and bloating, and it's really changed our life because we don't live in a constant state of having to think about what we're eating and are we going to be cramping so badly that day. So it's definitely been a really great experience, and now it's super important to us to try and spread awareness about endo, and we try to talk to all of our friends and people that we meet about it, especially because periods are really stigmatized and it's really normalized for them to be so painful. So we've been really excited to be a part of the mission of spreading awareness.
Yeah, as someone who personally, my pain wasn't just around my periods. I also think something with endo that people don't realize is sometimes for me it wasn't short periods of pain. It was actually kind of all the time. So I got really used to the pain. But after the surgery, I realized how inflamed my body was. Same with Lane in terms of I used to get so scared even just to eat because every time I think anything passed through my body, it was triggered a little bit. But yeah, we both feel really lucky that we were able to be treated so young because it's super rare to be treated this young and be in contact with such amazing surgeons at such a young age. So that's kind of a little bit about us, and we keep doing things as we should as people with endometriosis, and we feel a lot better.
Yes, thanks.
And Lane, your stories point out the problems experienced by many who suffer from endometriosis and will be very useful for those in the audience. We hope you will do well in the future. Our next speaker is Dr. Tamer Sekin on peritoneal endometriosis. Dr. Sekin is a pioneering endometriosis specialist and internationally renowned advanced laparoscopic surgeon. He has established a multi-specialty team to approach women suffering from debilitating pain with involvement of the bowels, urinary tract, ureters, and in extrapelvic locations. He is the founder and president of the Endometriosis Foundation of America. Tamara.
Thank you. I hope you guys are hearing me. Yes, I hope I'm not on mute. Thank you again, Dan. Your presentation was exceptional, as usual. I'm really touched by this Sister Rekan and Neve Lane, which I operated a year ago, approximately. And this is the type of endometriosis, peritoneal endometriosis, that I believe is the central element in endometriosis as a disease. As Dan pointed out, the prevalence of this disease can go up to 28% from 6% to 28%. Some is a condition. If there's no pain, there's no endometriosis. If there's pain, definitely if the symptoms really match, there's 90% endometriosis. There's so much to be known on that. Peritoneal endometriosis is the endometriosis that's very special to me, because my biggest challenge have been peritoneal endometriosis, because I recognize this as the main source of delay in diagnosis. Is the reason why endometriosis gets bad reputation. And it's the reason why women are blamed, the pain is in their head, because there's no test, blood test, or there's no imaging methodology. There, as Dan showed you, the lesions are less than 3 millimeters. Many of them are less than 1/5 of a millimeter. Only very meticulously experienced eyes can recognize that. So this takes me back to Blossom Bowl 2009. Almost 13 years ago, we had the first Blossom Bowl, and these Regan and Selena sisters were my patients again, which I was following for years. And they were around. This is a public story, so I can share it. They shared their story all over. They are the main reason I was so attracted and glued to these progressive type of endometriosis, which I follow these patients almost 10 years. They have been my patients, and then I operate them. I like to give some of her story to you, so it's very interesting. They're both lawyers, very educated, identical twins, and they both had endometriosis. This is Blossom Bowl 2019.
Like the fact that we have both pursued careers as lawyers, or that we both have been diagnosed with endometriosis. This fact highlights a troubling characteristic of this disease, its hereditary nature. When a woman is asked to give a family medical history, heart disease, cancer, diabetes, these are the medical conditions that are typically come to mind. Rarely are non-cancer GYN issues ever raised. While the impact of endometriosis on a woman's life can often be as emotionally and physically devastating as the better known hereditary conditions, tragically few women have ever heard of this disease, much less know that it is an important part of their family medical history. More so than probably any other aspect of our health, we rely on the women in our lives and in our families, our mothers, our sisters, our grandmothers and aunts, to inform and advise us as to how our bodies work. Sadly, the women in our lives can unwittingly perpetuate myths about pain and set unreasonable expectations as to what is normal. In fact, I took a strange bit of pride in sharing my mother's high threshold for pain and my ability to tough it out as traits that had served me well in my career. Unfortunately, they did not serve me well in my personal life. It is only when the physical pain that I had experienced on a monthly basis had become coupled with the emotional pain that was brought on by my inability to become pregnant with my first child that I began to suspect that what I had considered typical and acceptable was in fact not. I was fortunate, however, to have had a doctor who was knowledgeable enough to recognize that the agonies that I had pushed through and pushed myself to persevere through and accept as part of my life as a woman was not normal and should not be tolerated. It was thanks to Dr. Sechkin's accurate diagnosis and his surgical intervention that my endometriosis had been successfully treated. I look back in sheer amazement as to how and why I thought accepting physical torment and other symptoms of endometriosis was ever okay. Because I received an appropriate diagnosis and care, I was blessed to have given birth to a daughter of my own a few months ago. And I am so grateful that my diagnosis put a name on the pain and the symptoms that I had believed were a natural and normal part of being a woman. I am so happy and so pleased to know that the work that this foundation will be doing will mean that my daughter will not have to one day suffer unnecessarily. Thank you. Stories obviously will have some similarities, but while Franny spoke a little bit about the hereditary nature, I'm going to talk a little bit about this disease's impact on fertility. Unlike many of the women that are here tonight, my story is not a frustrating odyssey of misdiagnosis. Rather, my story is about optimism and the importance of early detection and treatment of endometriosis. I have been a patient of Dr. Sechkin's for 15 years. Shortly after one of my first visits, he quickly ascertained that I likely had endometriosis. I had never heard of this disease. I considered my intense monthly pain normal and dismissed Dr. Sechkin as a cut-happy surgeon. Well, after a few more years, a little research, and with no prospects for a suitable husband in sight, I agreed to have the laparoscopy in order to alleviate my monthly pain, and more importantly, for me to stave off the effect of the disease that would have on my fertility. Well, fast forward 10 years, newly married, thanks to Steve, and hoping to start a family at age 40, mind you. Dr. Sechkin, knowing my history and the severity of my disease, suggested another laparoscopy. The surgery confirmed that the endometriosis had aggressively returned. And at age 40, while other doctors would have been negative on my chances of conceiving, or would have pushed me right towards IVF, but Dr. Sechkin had a can-do attitude when it comes to this disease. And today, I'm the proud mom of a beautiful 7-month-old baby boy. Menstrual pain is dismissed as a necessary evil that must be tolerated. No one ever hears a young woman complain of severe menstrual cramps and thinks, quick, get her medical assistance. This is a matter of life and death. But in many ways, while endometriosis is not terminal, it is about life and death. Living a full and pain-free life every day is something everyone deserves. And the death of a dream is a great tragedy. Perhaps one of the most simple yet most pervasive dreams of any woman is motherhood. Yet month after month, without her knowledge, that dream is slowly eroded. As we go through our lives, through high school, college, perhaps grad school, start a career, we hope to meet a husband and start a family. But many women like me were not positioned to think about starting a family until well into our 30s. I was fortunate I had a doctor who recognized my symptoms early on and treated me appropriately and aggressively, which allowed me, with some help from my husband, at age 41, to give birth to my son Connor, and my twin sister, as she mentioned, 2 months later to give birth to her daughter. I have had many friends who have gone through the anguish of infertility issues, insemination, Clomid, IVF. And yet, when I ask them if their doctor has ruled out endometriosis, they very often have never heard of it, or the doctor has dismissed it outright. This ignorance really does need to be eradicated, and women need to be informed, properly and timely diagnosed, and treated appropriately so they can live pain-free lives and have the chance to see their dreams of a family come to life. Thank you, and thank you to Pat Malachny and Dr. Sechkin for doing everything.
Yes, so I have to be honest with you. I didn't want to interrupt their speech. It's a grand speech, twin sisters at the age of 40, and they naturally got pregnant. And I haven't rushed on them. I have followed them for almost 15 years. I know they had endo, but then it's hard to be accused of two lawyers telling me I'm a cut-happy surgeon with my aggressive treatment. yes, it was, and they accepted it. I was finally I was able to convince them. That's why today's presentation is so important. The Rekan, Nave, and Lane sisters were lucky to be diagnosed early in their lives. They are 21 years old. They had peritoneal endometriosis. I will show some of their pictures here, even though they allowed me to identify with the pictures, but you will not know which pictures are theirs due to my ethical concerns still, even though they allowed me to do so. So I want to wrap back to Dan Martin again. You know, Dan Martin has a special place in the history of endometriosis. For me, I think he's the one who really highlighted the importance of a non-typical occult, the endometriosis that is non-pigmented, that escapes the eyes. It's at its minimal lesion size with its pathological evidence. Dan has really opened many people's eyes, along with Victor Gomel before him, who taught us the microsurgical technique. Really, you cannot deal with endometriosis surgery if you don't care with the microsurgical technique. It becomes a total burn surgery. Certainly, my associate and also my mentor, Dr. Rich, Dr. Nezat, have special places in my training and progress in this field. No need to talk about Samson. Samson was the brain of many things that we do today, and he needs more respect, I think, by the endometriosis community. Samson did not have electron microscopy. Samson did not have immunostaining techniques or fancy genetic techniques to find. He did everything 100 years ago accurately. Yes, this is a quote from Dr. Redwine, which I think he elaborately always describes things much better than a lot of people. So this is a pigmented lesion. Around that, you see fibrosis. What you don't recognize is the shadow or the depth of lesion that may be here. We do not know that. On the left-hand side, though, there are occult lesions. Even though some are pigmented, you see more white around this than the pigmented lesion. These whites are also, there will be endometriosis in them. So I will tell you about this technique later, the ABC technique, aqua blue contrast technique later. Well, endometriosis is a disease of menstruation. It's a disease of endometrium that really manifests itself outside the uterus. So I put this because I gave a lecture to midwives. At that time, a big tanker had stuck in the Suez Canal. No one was able to rescue the tanker. It's the full moon and the tide that came, and that allowed the tanker to be free and basically got to its path. Perigee is when the moon is closest to the earth. It is the supermoon. What has it got to do with today's presentation? Well, there is a synchronization of human reproduction with the lunar cycle. In the ancient times, it is said that woman's most fertile phase is when the moon is not supermoon or full moon, during the time of ovulation, when there's new moon, when it is dark, there is more tendency for intimacy. And it is true, even in animals, badgers mate mainly during the darkest moon phases. Other than that, my hunch is the fullness of the moon and the tide may have something to do with the period and the other things that really optic nerve and the evolution of hypothalamus, that over the years, before we were even modern human beings, 50,000 years, for millions of years, the human brain evolution completed to synchronize with lunar cycles. With the present day, obviously modern day, with the light, electricity, females lost this synchronity. So endometriosis is a disease generally said to be treated everything else but for endometriosis. These two slides are example of two patients that I had. There are many of these type of cases that we see. This patient was treated for sacroiliac joint dislocation with pins and screws, with too many surgeries. You see this. This is what happens when endometriosis is delayed and derouted to something else other than endometriosis. These patients all had very advanced endometriosis that I had the chance to treat over the years. So there are really 3 types, maybe 4 types of endometriosis that audience should know: peritoneal endo, chocolate cyst, deep fibrotic, and infiltrating endo. There's a little nuance difference. Infiltrating versus fibrotic. Infiltrating means it infiltrates into the organs. You need to remove the organs. Deep fibrotic, it goes to the connective tissue between peritoneum and others. And there's extrapelvic, extraperitoneal endo, which is on the belly button, inguinal hernias, and also the chest and thoracic cavity. But for today's presentation, we are talking peritoneal endometriosis, the most important endometriosis that everybody misses. So I am claiming that if we diagnose endometriosis at its earliest stage, at the peritoneal stage, and treat, the ovarian and deep infiltrating endometriosis will be prevented, except maybe some rare cases of adenomyotic nodules of the version of the endometriosis. But most of the time, 95% of the time, I believe this is the case. So our challenge is to halt the disease at this stage of the peritoneum layer, where uterus is an important factor, uterine morphology, and I will get to that later. So peritoneum endometriosis has to be stopped. We will talk about that. So the disease is an extrauterine primarily pelvic peritoneal disease, and every location of the endometriosis is the evidence behind the symptoms. And I'm going to show you our data on this. I'm going to dive into the data because this is not published yet. This is my dream to publish. I have multiple doctors and medical students worked on these. It's very hard when you do biopsy, on the average 15 excisions per case, in some cases 23. It's very difficult to find correlation. But overall, this is the fact. The evidence lies in Lenox Hill Hospital pathology department. I have excised for the last 12, 13, almost 15 years, 14 years, over 25,000 excisions, and they were subjected to pathology. And I'm going to review this data, some of the findings, in a segmental version. Only 8,000 to 9,000 of them, we looked at their locations and laterality and everything. So this is what I am going to present you. So there is, this is the pelvis. Obviously, one should think that this pelvis peritoneum is wired like a microcircuit to the brain through its very fine nerves. Every vessel has a nerve that we do not see. So we put this pelvis into zones. This is cul-de-sac, through cul-de-sac, rectovaginal septum. This is broad ligament aspect of the ovarian fossa, with uterine artery reflection and uterosacral ligament. This is the zone 3 higher ovarian fossa, ovarian cleft, and hypogastric course of around ureter. And this is the psoas reflection on each side. So this is what we found. This is how we map every case. This is a sample. whenever it is every case, my associates, mostly them, they mark these locations in every sample. And in the end, we say we removed like 26 lesions, 14 was positive for endo, the rest was inflammation, fibrotic. We put them too because we consider inflammation is part of endometriosis pathology that gives symptoms. And fibrosis is probably old lesions that may be healed, right? So this is what we average age for peritoneal cases is less than 35. 70% of them was, this is rightly so. I mean, many of them right now, I think the data, this has shifted way to the 26 age or 26 years old group. So we're diagnosing them more early, much more early. Endometrioma cases, 34, 35. The hysterectomy cases, again, 36 to 46. Bowel resection cases are 36. And also average age for thoracic endometriosis, exactly 37. What this slide shows is in the disease, in the endometriosis which consider disease and require surgery, the disease is progressive. There's no doubt that the disease starts from the get-go as stage 4. It progresses. It progresses in some very slow, in some aggressively. We see I'm 23 years old with everything as bad as 43-year-old lady, or it stays same. That part will be discovered in the future. But when we look at the zones, zone 1, the true pelvis, is not the area where peritoneal endometriosis is more prevalent. It's the zone 3. This area where ovarian bed on the side gets more lesions and pathology at the minute way of expressing itself than zone 1 and zone 2. In other words, this area is more frequent, more for pathology than broad ligament and cul-de-sac. Even though we see more deep lesions on cul-de-sac and uterosacral ligaments. For peritoneal endometriosis, that's not the case. So, all right, we'll move on. So obviously, bladder, anterior cul-de-sac versus posterior cul-de-sac, there's more lesions on posterior cul-de-sac, and it is statistically positive, very convincing. 9/92, 91%. Similarly, in true cul-de-sac, left side of the rectovaginal septum gets the more lesions, this side. Why? Because I think we know that it is because the sigmoid comes like that. We'll get to that later. And also from the laterality, right pararectal area gets also more frequent lesions in cul-de-sac. So when we compare uterosacral ligaments, again, the left side gets more lesions in zone 2. Again, the left side get more uterine artery reflection lesions. In zone 3, there is more again on the left. Overall, on this presentation, left side is always predominant, and it is, most of them is statistically significant. We have to run more tests to claim this. But I'm going to come to good old Samson with this. I mean, the guy does not get credit, even disrespected by many who wants to be like him. And in another way, accuse him not being correct, but 99% of the time Samson was correct, as I told you before. And this is for the zone 4. So peritoneum is a very pristine, silky organ. It's beautiful, transparent. As you see here with my blue dye, it covers the whole pelvis, and it's a very beautiful organ, smooth, with shiny purposes, no abnormal vascularity, no fibrosis, no holes, no pores, translucent, plain texture. And subperitoneal connective tissue, loose areolar tissue you see here, is also beautiful as it protects the nerves, ureter, other structure underneath. Is an incredible elastic structure that is part of the incredible fluid transport to the peritoneal cavity. The peritoneum is an organ, really. It's been claimed by Gray Anatomy 2 years ago. Peritoneum and mesentery is claimed to be another organ. It's such a vital portion of the mesenteric bowel activity, which we will be coming, that is part of endometriosis symptoms. So again, the same slide that I showed you. So every part of this, every square millimeter has some nerves, demyelinated nerves that we don't see. Endobelly, constipation, late symptoms of endometriosis has all to do with the peritoneum and omentum and all the bowels that that is associated with endometriosis symptom, the bowel symptoms. Peritoneum is the key to understanding bowel symptoms and pain. Endobelly is part of this. This is another slide that shows the micro representation of the peritoneal pores, nerves, and the fluid transport. So peritoneal pelvis, when you look at it, the disease later takes place and cul-de-sac may get closed in the advanced stages, but it starts very early as implants here. And this is what happens later when the endometrioma breaks and everything. So this shows the anatomical landmarks. We pay attention. These violet areas are the nerves. They don't like what happens here, and all the impulses go here. And there are vital structures on. So if you do surgery, one has to know how to deal with the underneath neighboring structures. This is how rectum is related to vagina and posterior cervix, and this is the lateral aspect of the rectovaginal symptom in this 3D representation picture of mine. As it relates, the nerves are here, hypogastric nerve and psoas nerves that I take special history and physical to these patients, and we ask where the pain is, numbness is. We like them to point. We put this map on the screen. We let them to point where their pain and discomfort is. Again, these are the psoas nerves, and you know, we basically can see these nerves. Look at this ilioinguinal, lateral circumflex, and genitofemoral between the external iliac, and on most lateral, you see on the screen here is the iliohypogastric nerve that you saw. So the two theories behind the endometriosis is today's actually with modified of the old theories are gone, classic theories are gone. We believe endometriosis is a disease of the stem cells that inherit genetical signal for heavy bleeding, for the attachment of these cells, or even rebirth of the new lesions. The stem cells, which are capable of replicating themselves and also progressing into metaplastically turn into other tissues, is the key to understand endometriosis. And angiogenesis, spiraling of and sprouting new capillaries, as you see on the side, fantastic. Look at this angiogenesis here. Is the core pathological process that goes on endometriosis. So this slide shows representation. I've been criticized many times by some flat earthers that refute the role of retrograde periods. So we know that every woman has some degree of retrograde period. However, in some, it is so much for the body to fight. And that's how really disease may start. In every endo patient, as much as there is dysmenorrhea, there's as much hypermenorrhea or menorrhagia, heavy bleeding and clots from the get-go, from meningitis. So this part is difficult to clean in some, and it has a tendency to cause later. And on the left side, you see the evidence. I have many pictures of tube leaking during the period, which I do most of my surgeries during menstruation time. And first I look at the pelvis to demonstrate how much its retrograde bleeding is. So there are non-obstructive uterine outflow dysfunctions like cervical stenosis, particularly internal os stricture, natural maybe, very severely anteflexed, severely retroflexed, retroverted uteruses. Arcuate uterus is a main component of endometriosis, which has no obstetrical meaning. Uterine septum, bicornuate uterus, and others, and congenitally rudimentary horns and everything. So every surgery starts with examining the uterine cavity inside the womb and evaluate the architecture of the endometrium, and then we look from above with laparoscopy. So every endosurgery should be starting with somehow with examining the uterine cavity. Arcuate uterus is an important part. In one publication, we have a book chapter, up to 30% of the uteruses have some degree of abnormality without being by cornuate uterus or septum. There is arcuateness of this. This is the sonogram like a cat sign, 2 corneas, and this is the MRI. We see this. And this is the typical vertical strays with midline prominence, as well as bilateral corneal funneling we see on these cases. Usually tubal osteas are also dilated, and there could be polyps here. Interesting. Polyps are more prevalent with endo patients in the endometrium also. So this is an arcuate, this is a bicornuate uterus, tons of endometriosis at the peritoneal level in this case. This is how her cavity looked like. And this is a similar patient with a rudimentary horn with multiple polyps. And when I looked at inside, there was a rudimentary horn. I personally missed this. I was so focused on this endometrioma on the left side on this patient initially. So retrograde bleeding, you can see this much of blood even 2 weeks, 3 weeks after period in some patients. And usually, in this case, I have asked the pathologist to look at the clots I removed, this clot I removed, and she demonstrated the presence of glands there. And it's the same case. So only 2 weeks ago, I did another case. I begged the pathologist, please, this is the clot. I'm seeing it on a fossa here. Look at the inside. And she really found multiple glands in this slide, as you see. We could do CD10 on these, as Dr. Martin was talking about, but for pathologists, they don't feel even that's necessary. This is so pathogenomic for them to recognize these as endometrial glands and stroma. So what happens here is the disease really settles in the dependent surfaces. The bowels are active. It certainly is on the move. So disease, the clots and the endo finds itself on the pelvic side walls and caves and curves of the pelvic peritoneum. So it is not undependent by stable dependent surfaces rather than mobile surfaces. And in this case, you see wide variety of fibrosis with the presence of retrograde bleeding. And in this case, you see the pelvic side wall have sacs that would trap endo. So recurrent period will be trapped here. Like on this left side, this disease has gotten deeper in existence. One has to recognize this. This is not easy to recognize if you do not know what you're doing. And in case of endometrioma being ruptured, imagine these chocolate material will be trapped on the side. Again, this is a sample of the same thing. I'm going to move a little bit faster. So this is the rebirth of a lesion. I am happy always with my pictures. I kind of look at them continuously and think about them. So this is a very early lesion. that like a little mouse. But you see, it is with the irrigation, it is floating on the peritoneum, this lesion. It's anchored with small vessels to the peritoneal surface. So this is the birth of the lesion, as you see here. And this lesion eventually bleeds. These are the example of bleeding sprouts, and like this, as you saw. And most importantly, when you do underwater exam without the pressure of laparoscopy, these buds like swim like a little vesicles. Otherwise, you'll never be appreciating that how free they are in the peritoneal cavity. What makes these pathologies when they bleed? Eventually, they bleed probably during the menstrual time or some hormonal variations, but they all bleed and cause peritoneal further destruction and of the peritoneal mesothelium. And this is these vessel formations are magnificent in it's all angiogenesis, new vessel formation. Whenever there's angiogenesis, there is neurogenesis. All these vessels are equipped with nerve fibers, but we cannot see. Only we can see under pathology with special stains. It's been proven many, many, many times. So these are more pictures of the same concept. We're moving on. So these lesions could be concentric, increasing the surface tension. There are holes and pockets are formed and big nodules are formed eventually. But overall, this is peritoneal endometriosis. Every lesion, pigmented, non-pigmented, white is there. What you don't see is more. There's more that you cannot see. I'm going to show you. You think it's over. There's more you cannot see. There was papillary version of this, vesicular version of these, and more. And these really bleed, as I was just trying to tell you. This is a little clot again, formation. And this is a video that I show you how this thing really bleeds. I didn't touch this. This is basically actively bleeding from a floating vegetative lesions. And these are more sample of bleedings. And eventually, this is the extreme case. You see more bleeding where stage 4 endometriosis is there. And these lesions are thickened like a leather. There are holes around. And this is the aqua blue test. We dive under the blue dye and examine the peritoneum on a close way. And this is how I perform this. I make a small hole on the pelvic side wall and inject diluted methylene blue that would create contrast to block the retroperitoneal reflection of the red and yellow hues. But what you saw here is many holes here that we're just gonna go into, which you didn't see before. You cannot see this unless you do this test. These holes are really the mainstay of the definition of the inflammation beyond the, you see there's a lesion here actually, hidden behind white lesion, but the rest is all distorted peritoneum and the other under subperitoneal tissues are exposed through those holes. It's the same holes. My theory is that the same holes that cause a diaphragmatic endo leading to holes in the central tendon. So these holes are, when you give tissue pressure with water, they are true holes that you see, it leaks water like that. I'm coming to the end of my presentation. This is diaphragma holes, but so it's the same hole that causes the central tendon deficiency. So if I didn't do this, I may be missing this fibrosis. This is previously burned area that had still endo around, multiple things around, yeah. Oops, I'm sorry, I went forward. My apologies. Almost done. Okay, this is the patient we just did, 19-year-old I put this because the patient has been on birth control pills for 6 years, still having GI symptoms, still having symptoms despite she's taking birth control pills religiously. You see, if you look at this, you don't see anything. There's no way you can say there's endometriosis because it's shining, the light is shining, even with the proximity. When you do the aqua blue, you see multiple lesions around. This patient also had very abnormal appendix. Probably that's also, many times these increased vascularity spiralization is the key to appendiceal lesion that explains the bloating, gas, a lot of bowel symptoms, which you don't see classic endometriosis here, but a good pathologist will find lesions there. Okay, we came to the end of my presentation almost. This is fulguration, which I deplore, and I am really discourage anyone whose doctor is tending to go this type of surgery. There is no tissue biopsy. You cannot really reach to the deep of the lesions, and it creates more burn tissue, and impales or pins the whole lesion to the retroperitoneal organs. Maybe it may even cause more pain. This is the laser version of the same procedure. It's cleaner, but the same concept. There is no tissue biopsy. In this, you excise like this. If you're in rectum or other places, that's why you're a good surgeon. You repair it. The patient is cleared of all of their lesion. The purpose of an excision surgeries is to perform complete surgery, leading to tissue diagnosis. This is how it happens. Basically, this is a adjacent forceps. This is a cold excision. You basically cut without any electricity, particularly on the ovaries. You excise these and send to pathology. And many times, if you have a good pathologist, she will show you where the endometriosis is. Sometimes they exhaust. Every lesion has to be, in my practice, every lesions are cut separately. This is cold excision. We cut this without burning. In this case, I'm using smaller 3 millimeter instruments. I had to use because my scissors were not working that day. This happened just last week. I want to share with you. In this case, we really, the patient completely cul-de-sac was restored. And additionally, diaphragm was excised in the same patient. You see how it was, and these are diaphragm muscles. And this is how it looked. This is focal excision based on directed excision to the abnormal pathology. We don't remove normal peritoneum. It's not peritoneal stripping, just the opposite, okay? Same way, these are ovarian suspensions, and aqua blue contrast, ovarian suspension, and uterine lift has been my technique that I perform, so it diminishes postoperative adhesions. Similarly, this is the uterine lift, uterine suspension that you see, part of the excision surgery. There's more to endometriosis that we can see. Each lesions has to be, preferably excised separately. Peritoneal pores are a sign of inflammation. They are best recognized by retroperitoneal contrast. Effective revealing of lesion impacts outcome. Excision must include porous peritoneum. Tissues must be examined under microscope. And this is rare case, but 1 in every year I get one patient. We see some degree of cancer, atypia leading to ovarian cancer. Early detection, management of symptoms, accurate diagnosis, and timely intervention by excision of the peritoneal endometriosis is the best prevention. I said this 1996 in a presentation in Croatia, that I think I hold on this philosophy, and that's why the foundation was formed. I thank my partners and my board of directors. We came to the point that we were very instrumental to initiate more than 90 million this year. It's going to be major news coming up. You're the first one to hear this, even though Padma Lakshmi already tweeted. We were very instrumental to increase endometriosis research money from 9 million, then it became 26, now it is 92 million. It's the same for the same purpose. Personalized care and the importance of patient-doctor relationship is the key. It's part of the evidence. It should be the part of the evidence pyramid. Otherwise, in the evidence-based medicine, patient and surgeons don't count. I like to really thank my associate, Dr. Carly Goldstein on the left with her beautiful smile, and another beautiful slide by Dr. Amanda Chu. And this is something from one of our patients we learned. It's Danish, life can only be understood backwards. It must be lived forwards. We learn from others and we exercise with caution. And my last slide, please find time for the things that make you feel happy to be alive. I really appreciate your attention. It's been a little bit more than usual. It's a long presentation. We love you. Take care. I'm here to answer your question. And this is my email on the side. If you need to reach me separately, please don't hesitate. Thank you so much.
Thank you, Dr. Second, for an excellent presentation and for sharing your knowledge on superficial endometriosis. I have an announcement for the audience who have questions. On the left margin, if you're in the lobby, there's a question and answer feedback button for entering those questions. Our next speaker will be Dr. Keith Isaacson on adenomyosis. Dr. Isaacson was the Divisional Director of Reproductive Endocrinology and Infertility at Massachusetts General Hospital until 2001, when he opened a Center for Minimally Invasive Surgery and Infertility at Newton Wellesley Hospital. He is currently Director of the Residency and the Fellowship, and is the co-director of the Center for Gynecopathology Research at the Massachusetts Institute of Technology. Thank you, Dr. Isaacson.
Good morning. It's a pleasure to be with you in the 2022 session of the Endometriosis Foundation Association. I want to thank Drs. Sechkin and Drs. Dan Martin for inviting me to participate and being with you here virtually and recorded for this important patient information session. My name is Keith Isaacson. I'm at Newton Wellesley Hospital in Boston, and I'm associate professor of OBGYN at Harvard Medical School, where I've been since 1989. And my passion and research has been in endometriosis and adenomyosis, and therefore I'm happy to carry out this discussion with you, and then be with you live on Saturday to answer any questions and continue the discussion. But my topic this morning is the following. Dr. So-and-so, I was told my pain was due to endometriosis. Could it be from adenomyosis? And first, I want to just explain what is adenomyosis. So we're all familiar with endometriosis, in which there's the presence of these glandular cells, as well as these stromal cells that normally line the endometrium of the uterus. And these cells should only be located inside the uterine cavity. When they're found outside the uterus, such as on the ovary of the bowel or the peritoneal surface, it's called endometriosis. But when these cells are deep into the muscle of the uterus, and here we see the muscle of the uterus, and down deep into the muscle of the uterus, you can see the presence of these same glandular structures and stromal cell structures. And that's when it's called adenomyosis. So why is this so important? Well, when patients present to their healthcare provider, and we're going to talk about this in a little more detail, they present usually with a complaint of either painful periods, painful intercourse, a deep pelvic pain, sometimes a back pain or low abdominal pain. We've heard it called endometriosis belly, and often they can present with infertility. And what happens is a physician will say, you know, it sure sounds like you might have endometriosis. They may or may not offer you a laparoscopy in which various stages of endometriosis can be diagnosed. Most commonly in 75% of patients, it's very early stage 1 or stage 2. And when they treat this either by excision or a combination of excision and hormonal therapy, about 75% of people feel better when they're on the hormonal therapy, but there's a high recurrence. So the question is, if you're having pain that seems to be coming from the uterus and not necessarily outside the uterus, so these symptoms include, again, painful periods, heavy periods, pain with intercourse, it's most likely that the pain is coming from the uterus itself and not disease outside the uterus. And therefore, it's reasonable to discuss with your healthcare provider, okay, I might have some endometriosis, but is it possible that there's also adenomyosis, or another term is like endometriosis in the muscle of the uterus, that can be causing this pain? And I show you this picture to the right here to show you what a uterus looks like. And here you see the lining of the uterus. This is the, let's say, the posterior muscle of the uterus. And this side of the uterus should look the same as this side. But what you can see on this side is that this is very thickened. If you were to examine it, you would see that there's a lot of overgrowth of muscle, there's a lot of inflammation, and there are a lot of glandular networks in here. And my message to you today is to ask your physician, you know, is it possible that, yes, I may or may not have endometriosis, but could I also have adenomyosis? And how could we diagnose that? And is the treatment any different from endometriosis? And let's go through that a little bit. But first, I want to take you back in history, because we're currently at a stage now of recognition of adenomyosis where we were with endometriosis way back in the 1970s. And let me tell you why I say that. So back in the 70s, we were just starting to do laparoscopy. And this is from a textbook in 1979, in which they were trying to describe what patients actually get endometriosis. And what is described here in this book, and again from 1979, it seems that, I'll read it to you. Typically, our patients with endometriosis appear to have an intense desire to excel. They're perfectionists with demanding and specific goals. They are usually well-dressed and have trim figures. Most are employed in secretarial positions or in professions such as law, medicine, or teaching. And once aware of an infertility problem, many patients have an obsessive desire to conceive. So I bring this up because why is it that way back in the 70s, it was felt that, only 3.4% of the patients who had endometriosis were African American or Black? Well, the reason for this was these were the only patients who were getting laparoscopy in the 70s. It's not the only patients who were having complaints, it's the only patients who were getting diagnosed. And it wasn't until the 80s and the 90s when laparoscopy became the standard of care and we could diagnose this, that we found out that endometriosis actually affects women equally of all races, and that it certainly is found in younger women as well as older women in the reproductive age. And that's kind of where we are with adenomyosis, and I'll explain that. But to make this point, I want you to think about the following. We know that a lot of women, even as early as in their high school years, when they're just getting their periods, complain of severely painful periods. As a matter of fact, 15% of girls in high school miss at least one day a month from school because of heavy, painful periods, or a combination of both. And often when they undergo a laparoscopy, you see these little clear lesions. And most often when those clear lesions are biopsied, it turns out most of them are 63% of them are actually non-diagnostic, which means that there's really no evidence of endometriosis. So 30% of these girls in high school also having cyclic bowel symptoms, constipation, diarrhea. So we're looking at them and making the diagnosis and giving the patient the diagnosis, oh, you have endometriosis, that's what's causing your problem. Where in reality, that may not actually be the case. They may have some clear blebs, but by definition, those are not endometriotic lesions. So again, endometriosis, as we know, because we started doing laparoscopy on much more commonly to make the diagnosis, is that we know that the age of onset can be earlier. We know that the symptoms of endometriosis, again, can vary greatly. We know that it affects women of all, again, ages and races and what have you in the reproductive age. And we know that when you look at a lesion laparoscopically, that some of them look like little black lesions, others are red. But again, in the adolescent and those who are complaining mostly of painful periods at a young age, what you see are these little clear blebs. And it's so important that these blebs be excised and be biopsied, not because the excision is going to necessarily take care of the pain, because you're going to find out that most of those lesions that look like this are truly not endometriosis, and they probably don't explain the pain that the patient is suffering. So the question is, what's causing the pain, and why do some of these patients who get this excised actually have pain relief? And the answer to that is that all these patients after it's excised get put on some type of hormonal suppression, and that's probably what's causing their pain relief. So here we are with adenomyosis and where we were in the 1990s. And I compare that to where we were with laparoscopy, with endometriosis in the 1970s. So we thought in the 90s and the early 2000s that adenomyosis, which is that endometriosis of the muscle of the uterus, mostly occurs in women in the 4th and 5th decade of their life. You're at higher risk for having adenomyosis if you have children, whether it's done through C-section or from vaginal delivery, and that the frequency of the adenomyosis increased with the number of pregnancy. Well, it turns out the way we made the diagnosis of adenomyosis prior to about 4 to 5 years ago was by hysterectomy. And these risk factors that you see, which include having children and being in the fourth, fifth decade of life, is really a risk factor for patients who are going to have their uterus removed, not necessarily for adenomyosis. So think about it. If a woman has adenomyosis who's in the young college age, she's clearly going to have the symptoms of painful periods, heavy periods, but she's not going to have a hysterectomy prior to having children, more than likely. And therefore, the disease was not found in that patient population. Now, where are we in 2021? We know that not only is adenomyosis common among all women of all ethnicities, we also know that it's common in adolescent women. And we also know that it can be responsible for not only heavy, painful periods, but for fertility issues as well. So how do we miss it all these years? Well, we tend to diagnose what we can see. And if a person has adenomyosis and is getting a laparoscopy, the surgeon can only see the outside of the uterus. They can't see inside the muscle. So if they can't see it, then either they say it's not there or it's certainly not diagnosed. So again, in the past, the diagnosis was made by hysterectomy. And now the reason we are seeing it and making the diagnosis is because we have much better screening tools such as ultrasound, and MRI is also a very good tool to diagnose adenomyosis, but it's expensive and it's not a good screening tool. But the vaginal probe ultrasound is, and both of the MRI and the ultrasound are about 80% predictive in finding adenomyosis. And I just show you this one example because this was a 16-year-old girl who was having severely painful periods to the point where she was missing school a couple of days each month. And she came into my office and she had already had a laparoscopy, and they said, yes, you have clear blebs of endometriosis. Put her on a birth control pill, continuous pill, but she was still having pain. And what I show you with this ultrasound here is fairly obvious. So here's the entire area. This is the uterus. This is the lining of the uterus, the endometrium. But if you look here, this is a little cyst of, almost looks like an endometrioma in the ovary, but it's in the muscle of the uterus. And it's pretty clear that's a focus area of adenomyosis. And it makes sense, finally, that if someone has disease or symptoms that are related to the uterus, such as heavy, painful periods, that the disease is actually in the uterus. And now, with ultrasound, we're pretty good at making that diagnosis. So this has been borne out with several studies now, and that Karina Exuskustos, who's one of the premier ultrasonographers for endometriosis and adenomyosis, has been looking at all these patients who were told that they had endometriosis based on laparoscopy and were adolescents. And in almost half, and 44% of them, she actually found lesions in the uterus that was most consistent with adenomyosis. So if we start looking for it, we're going to find it. And we've also seen that adenomyosis affects infertility. So we've now seen patients who have recurrent pregnancy loss or recurrent miscarriages, patients who are undergoing in vitro fertilization and you put in a very good embryo and it's just not implanting. So these implantation failures all seem to be related to a disease of the uterus, which makes sense, which is adenomyosis. And if you actually look at patients with adenomyosis and you look at the live birth rates in those who are trying to get pregnant, there's a 41% decrease in the live birth rate in patients that had adenomyosis versus those that don't. So it's so common now that it's been suggested that when a couple undergoes an infertility evaluation, that adenomyosis or a vaginal probe ultrasound be considered as a normal screening tool, just to look for these cystic lesions here, 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 and here, which are consistent with adenomyosis, and that now we are pretty clear can affect their fertility potential. So I want to go through one particular patient just to give you surgically, what does this look like? This is a 37-year-old patient who had 6 miscarriages, and she had 8 years of very heavy menstrual bleeding lasting 4 days. She did not have any painful periods, but she did have pain with intercourse. And it makes sense. The reason adenomyosis can be associated with that is because adenomyosis causes like an inflammation of the entire uterus. And when it's traumatized with intercourse, it can be painful. So an ultrasound and an MRI were done. And here's the MRI of the uterus, and here's the lining. And just adjacent to the lining in this area here, in this area here, are areas consistent with adenomyosis. Here's the same patient by ultrasound, and it's harder to see, but this area here correlates with this area here. So a hysteroscopic excision was actually done in this patient. And what's fascinating to see is once this was done, you could actually see the glands of a glandular network within the muscle of the uterus. And that's what this tissue is right here. And so you can see that not only is the muscle not normal, but there's an entire system of glands going all the way through the muscle. And that's a pretty classic case of adenomyosis. So that brings me to the last segment before I stop, which is we are rapidly learning more and more about adenomyosis. My own bias is that I think it's more common than endometriosis. I think all patients who have endometriosis and have severely painful periods due to severe cramping likely have adenomyosis either instead of endometriosis or in addition to it. But I think, again, I want you to start thinking to yourself and asking your provider, if my symptoms seem to be uterine related, do I have a normal uterus or a uterus with adenomyosis? And unfortunately, there's not a lot of NIH funding for either endometriosis or adenomyosis, and we're trying to change that. But I work carefully and closely with Linda Griffith at MIT at the Center for Gynecopathology Research, and we're constantly trying to get funding for our research. But I just want to show you some of the more recent images that have resulted from our research. And this is a study called CLEAR, in which you can take a section of muscle, clear out the lipids, and actually stain for glands. And here's a patient with adenomyosis, and you can actually see the glands stain throughout the entire this entire section of muscle. So it's not like it's just one little gland there. There's a whole network of glands that can form within the muscle. and it helps us understand better what is going on. And once we understand the mechanism, we're going to be able to treat it much more efficiently. So we've got a ways to go. But not only can we look at the glandular network, but here is a section of muscle in a patient that has adenomyosis. So the uterus is about 95%, 98% muscle. And that muscle is very important that it contracts in a very coordinated fashion. So it contracts when a woman ovulates, it contracts when there's implantation, it contracts obviously when a woman delivers, and it contracts when you have a period so that you can squeeze off the blood supply and allow for coagulation so a woman doesn't have hemorrhaging with each period. So why do they hemorrhage when they have, often hemorrhage when they have adenomyosis? Well, this shows a couple of things. This is all muscle. And this shows that there's increased nerve fibers throughout the muscle, which explains why there's more pain. And it also shows that this does not allow for any coordinated contraction. So instead of being able to contract and cut off the blood vessel, there's a more spasm in the uterine muscle that causes more pain and causes more heavy bleeding because there's inefficient contractions. So again, just looking at these images gives a little bit more insight into the mechanism of why it would cause the symptoms that women present with. So to summarize in my final slide, just some take-home points here. Again, if a woman has symptoms that seem to be related to the uterus, such as painful menses, heavy menses, painful intercourse, back pain, cyclic bloating or irritability, infertility, recurrent miscarriage, ask the healthcare provider, is it possible that I have adenomyosis as well as or instead of endometriosis? And if they are familiar with adenomyosis, they will order either an ultrasound to look for it or an MRI. And then if it's found, the next discussion with the healthcare provider is there a different treatment for each condition? Because there are. You typically don't go in and excise adenomyosis because you'd be removing a large portion of the uterus. So other treatments right now tend to be hormonal. There is a surgical treatment for adenomyosis when everything else fails, but it has significant risks associated with it. So I think it's the key point for this discussion, be aware that adenomyosis is at least as common, if not more so, than endometriosis. And in my opinion, it's probably more likely to be causing the most common symptoms that are currently associated with endometriosis. I thank you for your time, and I will be with you Saturday live, and look forward to having further discussions and answering any questions that I can. Thank you very much.
Heads up, I'm on. Thank you, Dr. Isaacson. You point out well the difficulties that adenomyosis presents to our patients. We're now going to have a short question and answer session followed by a break. So we will be joined by, let me get back to there, Nave and Lane, Raycon, and also Dr. Second. My first question is going to be to Neve and Lane. What else would you add to what has been said today?
Hi there. Thank you so much for having us. I would say my biggest, the one message that I really like to say, especially to young people our age, is just to ask for help. And don't be afraid to go to doctors and be aware of your symptoms. I think it's so important for like awareness around our age because there's such a small percentage of people that find out that they're diagnosed at a young age. So I really think that my biggest goal is to spread awareness at a young age. And I think that's really important, but I am really excited to be a part of today.
Thank you, Lane. Neve, what would you add to that?
I think I totally agree. I feel really lucky that Lane and I had the exposure to knowing what endo was before, like as young people, because our mom had it. But I would agree in terms of some of the symptoms are super normalized with, all of them, especially young people, with how much pain you can be in. But so I would kind of add to that. And then in addition, just not, I guess this is in general, but kind of normalizing talking about things to do with periods and sex and all those kind of like, some people think of awkward topics, but a lot of them are actually really connected to your health. So yeah, just not being afraid necessarily to talk to who you feel comfortable with, because usually it's more important than just being, I guess, uncomfortable. It's, yeah.
Thank you. We're glad that both of you were able to join us today and look forward to hearing from you in the future. Our next question comes from the question and answer panel. I was diagnosed with adenomyosis prior to having hysterectomy surgery. During surgery, the doctor also discussed a great deal of endometriosis and removed a lot, but I'm almost 2 years post-surgery and still deal with endometriosis symptoms. So this is for Dr. Seckin. So she still has symptoms after her hysterectomy. Should she have her ovaries removed also?
Okay, that's a $1 million question again. Certainly, there's a hesitancy. No one wants to remove the hormone source, which is the ovaries are the juice for youth and everything else women can represent. So I'm always reluctant to remove ovaries. I would certainly look at the operative report, and from the operative report, I would understand to what degree of meticulousness her surgery was done. I will look at the pathology report. I know what that surgeon have done. I could just by looking at it can tell the quality of surgery that person received. And is there any video, pictures of the surgery and the pathology report? Those tell me whether the surgery is complete or not. If the surgery is not complete, many times in our practice, 80% or 90% of the patients are reoperative patients who had surgery before. It's always incomplete surgery. And the methodology of surgery is burning or lasering or things, or robotic approach, this, that. So if the hysterectomy is not the treatment of endometriosis, because endometriosis is a disease outside the uterus as it goes, as I explained. So ovaries doesn't need to be removed. In some cases it could be, but it is, again, intraoperative decision, or it's an elective decision by the patient. It depends what the situation is. Thank you for the opportunity to answer as much as I can to this question.
Thank you, Dr. Seckin. I'm going to take one more question because it's a 123-year-old question. Is it possible for superficial endometriosis to hide under adhesion attachment sites? The reason this is a 123-year question is because the first time that was discussed was in 1899. When William Russell found endometriosis in a normal appearing ovary, his surgery was for cancer in the other ovary. But they took out the healthy ovary also, except there were just little shreds of adhesions on the surface. And if you look at the top red circle and the bottom red circle, both of those areas are the endometriosis that he did not see that are hidden under adhesions. And in the middle was endometriosis deep within the ovary. It's difficult to find all endometriosis. So when we're looking in there, we have to be aware that endometriosis can hide from us. It can hide behind adhesions. It can hide inside ovaries. It can hide inside any other organ. So I'm going to stop.
I want to add something to that. Yes. I personally vehemently reject the term superficial endometriosis. Superficiality makes the woman's symptoms also superficial and undermine the seriousness of the disease. It is defined as peritoneal endometriosis. Samson called it peritoneal endometriosis, and Done and Nisol called it peritoneal endometriosis. I think then we have to really look at this issue, because superficial endometriosis, many times it's not superficial, always microscopically it's under some fibrosis. The nature of the disease is sinking into the pockets of the peritoneum. So also to answer the question, yes, there is endometriosis hides behind other adhesions. That's why it looks white. That's why it looks non-pigmented. That's why it is mist. That's why the aqua blue contrast brings all those things to visibility much more in my practice. Also, the issue with the adenomyosis presentation, when I invited adenomyosis specialists 6-7 years ago to my conferences, they said, well, why would we be there? There's no need to come there, because I only talk about adenomyosis, not endometriosis. So every doctor is like holding the part of elephant. Everybody defines endometriosis from their angle of practice. Patients define from the angle of their symptoms. Doctors define from the angle of their practice. If you're a laparoscopist, you are more endo. If you're a hysteroscopist, you see different things. If you're a sonographer, you see different things. We have way to go on this. That's why we're together today. Thank you very much for beautiful questions, but it's impossible to answer all of them.
Thank you, Dr. Seckin. What we're going to take is about a 5-minute break, so everybody can, if you got to, do what you need to do, grab your extra drinks, anything else, and we'll be back to restart. We're going to take about a 5-minute break, and we'll be back to restart at about 11:56.
Thank you.
Back on hold now for a moment. Thank you. We're ready to return. I'm watching the lobby. My signal says that I'm on, but the lobby doesn't look like I'm on, so I'm still confused. Okay, what I'm going to assume is that my view of the lobby is not working right, and I'm going to continue as though it is working right. So our next presentation is going to be from Dr. Catherine Burns on immunology and menstrual fluid. Dr. Burns is the Assistant Professor of Environmental and Public Health Sciences at the University of Cincinnati College of Medicine. She has studied endometriosis since her postdoctoral research at the National Institute of Environmental Health and Sciences. And she currently studies how the immune system interacts with endocrine disrupting chemicals.
Hi, everybody, and welcome today to Patient Day. And I am thrilled to be here speaking to all of you. And I hope together we can learn something about immunology and menstrual fluid and endometriosis. So I want to say a special thank you to the Endometriosis Foundation of America for inviting me to be here today and for all of their support that they've shown me throughout the years. But before we really get into what immunology and menstrual fluid and endometriosis is, we need to have an understanding of what immunology is from a basic background. So our body is completely assaulted every day with, in this case, we have parasites and bacteria and our more well-known COVID-19 that we've all been facing. But typically, our immune system is able to fight these off and keep us well. Now, in the case of myself right now, my face is, I have shingles. So my immune system hasn't fought off the chickenpox virus that I got in my body when I was 5 many years ago. So it's interesting how our immune systems respond and survey our bodies continuously every day. And why this is important, and there are 2 different steps of and areas of the immune system being called the innate immunity and adaptive immunity. The innate immune side includes macrophages, neutrophils, dendritic cells, eosinophils, and basophils. And how I like to think of them as they're the first responders. So these are the people and the cell types that come right in if you get a cut, if you get hurt, and they stabilize you. They make sure that you are able to make it to the adaptive immune phase, which consists of then the B and T cells. And I often think of this then as our trauma surgeons and the surgeons that will make sure we're put back together correctly and that we stay well. However, they not only fight specific wounds and bacteria and fungi and parasites, they also survey our immune system. They survey our body continuously to remove dead or dying cells, and those cells are part of this innate immune system. And this is important for us because people who menstruate throughout the menstrual cycle, there's dynamic changes that occur almost daily, and this coincides with the ovarian cycle. So as follicles in the ovary grow, so do the levels of estrogen. Estrogen gets to a high enough level. This causes the uterus to proliferate, the endometrium to proliferate. Once estrogen is high enough, it causes luteinizing hormone to, in a sense, in this case, smack the ovary and the follicle to release the egg during ovulation. Once ovulation occurs, there is the part of the follicle that's left over called the corpus luteum, and that will make progesterone. At the same time, in the uterus then enters the secretory phase. However, if conception doesn't occur, and that occurs around this phase where my pointer is now, eventually menstruation will occur. And importantly, menstruation normally enters into the picture when we have the endometrium that leaves out through the cervix and vagina, creating normal menstruation. However, there's a phenomenon that happens in almost all women in which there's retrograde flow, and some of the endometrium and tissue flows back through the oviduct and out into the peritoneal cavity. Importantly, in the uterine lining during these times, there are an increase in anti-inflammatory macrophages, an increase in the neutrophils, and an increase in some of natural killer cells. This is all believed to lead to clearance of cell debris, tissue regeneration, angiogenesis or development of a blood supply if embryo implantation occurs and conception is in place. So on the flip side though, what happens and believed to happen in endometriosis is through retrograde flow. Some of these lesions are able to attach and develop in the peritoneal cavity. Now, mind you, there are multiple theories on how endometriosis develops. This is just one of them. But the idea behind this is that in the uterine lining in women with endometriosis, they have an increase in macrophages that are more pro-inflammatory. They also have these increased neutrophils, as do physiologic women. But there's a decrease in the natural killer cells, which indicates that there may be a decrease in the cytotoxic effects, which are the ability to remove the tissue that flows back into the peritoneal cavity. This would then lead to an invasion of the immune system, which would allow potentially for lesion attachment, the development of the blood supply to the lesions, tissue remodeling that occurs, lesion progression, and adhesion formation. And all of this would then lead to the development of different stages of endometriosis disease. All of this is important because our research that we've done in animal models, looking at the development of lesions, and in this case, what I'm showing is there's kind of 4 different stages of endometriosis in which the tissue attaches in the peritoneal cavity, it develops a blood supply, or it's called angiogenesis. There's a level of patterning that occurs in the lesion to look actually and remodel like the uterine tissue. There's also then the immune modulation that occurs, and eventually this leads to level of these cells being proliferative and undergoing different types of signaling. Importantly, our mouse model showed that there's 2 independent phases. The initiation phase, or the beginning of disease, seems to be immune predominant and doesn't necessarily rely on hormones. And this coincides and makes a lot of sense because during menstruation, that's when hormones are very low in the entire body, the estrogen and progesterone. However, then, about day 7, 8, and when hormones start to rise, it appears that there's a progression phase, and the progression phase then leads to the hormone predominant phase of lesion development, where you have these lesions that are organized and proliferate and respond in the peritoneal cavity. All of this takes us then to looking at menstruation. Menstruation is an extremely inflammatory process, and the image that I'm showing you over here is just to give you a visualization of how the immune system, there's a number of different types of cells in the immune system that are important in the different phases of endometriosis. I'm sorry, during menstruation, I apologize, during the proliferative, secretory, and premenstrual phase. So the immune system and all of those immune cells that I'm showing you on the left are important for scavenging menstrual debris. And the idea in women with endometriosis is that there could be defective immune response to this reflux debris, which would allow for survival and implantation of ectopic endometrial cells and lesion formation. There appears that there are some alterations in both the innate and the adaptive immunity, and these are thought to contribute to the pathogenesis of endometriosis. So what we're doing in my lab and what we're trying to understand is we know that there's a basic level of these cell types. Now, these cell types can do different things in the immune system, and they can have different activation states that allow them to do different things. And that's where we're starting to study menstrual fluid. And this has been one of the coolest projects that I've really had the pleasure of doing in the lab. It's not fun to do and work with menstrual fluid, but it is amazing some of the results that we're starting to see. So what we do, and I'm showing you how we do this, is we take the menstrual fluid and we collect this by Diva Cup, and I have to put a shout out to Diva Cup because they donated the menstrual cups that we are using for our study and are allowing us then to collect all of this fluid from different types of women, both with and without endometriosis. Once we collect this fluid, we collect fluid on days 1 and day 2 of menstruation. We filter that through a mesh and strainers, and we keep the acellular portion of this to see what might be happening and what these cells are secreting. So we're looking totally just at protein in this analysis that we'll be doing in the future. However, what happens then with the cells that are here on the bottom of this and are full of red blood cells and white blood cells is we do a series of what are called Percol density gradients, in which then we take out the layers of immune cells that are important, that are the white blood cells that are important in menstruation. And we're doing then detailed immunophenotyping on these cells, which means that we're looking at what these cells are expressing on the outside of their cell to tell us what they're able to do as far as attack tissue that's going back into the peritoneal cavity or help tissue be released from the uterus and out through then the cervix and vagina. And we're then visualizing them. So what I want to show you is what menstrual fluid looks like when you take away all or most of the red blood cells. So here's a image of a red blood cell. So this is let me back up a second. This is an image of what is called a differential, in which we stain the immune cells to be able to visualize the cell types that are in the menstrual fluid. So we're looking at a red blood cell, and you can see that red blood cells are quite small. We're then also finding macrophages, and in this case, this one is a bigger one, which has some activation to it because it has these white vacuoles. Looking then, we also see a large number of neutrophils. So these are the more pink cells with the very interesting shaped nuclei that are found in them. We also find eosinophils, and you can see one there and one there. These are actually more involved, we're finding, in the second day of menstruation. And then you have your adaptive immune cells, which are your B, your T, or your uterine natural killer cells. These are much harder to tell apart visually, and that's why we must stain them to understand what's going on in the menstrual fluid. So I have a request, and that is you are likely 1 in 10 of the women who have endometriosis. So as it says at the top of my slide, we want your menstrual fluid. So if you want to be part of the study and we want to visualize your cells and actually see what might be happening in women with endometriosis compared to normal women, please email me at catherine.burns@uc.edu. And what we can do is see if you qualify for the study and see if you are able to participate and help us understand what the activation states of these cell types are that could potentially lead to endometriosis. Now, all of these cells are, as I mentioned, a part of our immune system. And another part of the research that we do in my lab is to try to understand what environmental chemicals or toxicants may do to the immune system, or how they may affect lesion development or lesion progression. So quickly, a couple of definitions. Endocrine disrupting chemicals act on our endocrine system, which regulates our entire body by hormones. These chemicals mimic, block, or interfere with natural hormonal regulation. And then the chemicals called immunotoxicants have adverse effects such as drugs, chemicals, or environmental agents that affect the structure and function of our immune system. And all of these are important. And some of the things that I like to point out is that now we're learning that a lot of the things that are being banned and removed, so if you see that things are BPA free or phthalate free, those are examples I'm going to be talking about. Some of these chemicals are being removed and they're just being replaced with chemicals that are just as harmful or potentially worse. And these are being called regrettable substitutions. And I'll talk a little bit more about that in a couple slides. So one of the first questions we wanted to ask with the environment is, do these environmental toxicants contribute to either the initiation or progression of endometriosis? We focused on the progression first by looking at the bisphenols, or BPA. And you may have heard about these through the making of polycarbonate or hard clear plastics. Typically they have a number 3 and 7. And what's happened in the last 10 years is that there's been an incredible change in what products contain BPA, and that they're now BPA free. In some cases, and not in all of them because they're proprietary information and we're not allowed to know, is that some of them are being replaced with other chemicals. And in this case, this one is a regrettable substitution because this is a fluorinated version of BPA, which is called BPA-F. And you will actually find that BPA-F is widely used as a cross-linking agent, and it's being produced now as mass amounts in the United States. But one of the things that started this research is that BPA was found to be more abundant in the serum of women with endometriosis. So some of our studies in the lab I did as a postdoc were looking at some of the estrogenic properties of these chemicals, and we found that this one in particular, BPA-F, had more estrogenic properties than its parent compound. So we did a series of studies with both BPA and BPA-F in endometriosis in animal models, and we found that our studies suggest that estrogenic chemicals affect progression of disease, and more specifically that BPA-F at lower doses has more of an effect of its parent compound, leading us to see that this truly is a regrettable substitution, and we need to be careful with what we're using in our products daily. We then went on to ask, what's happening potentially with the initiation of disease? And as I mentioned before, the initiation seems to have more to do with the immune system. So we wanted to dig deeper into the literature and try to understand if there were any immunotoxicants that could play a role in this initiation of disease. And what we found were chemicals called phthalates. And there are high concentrations in plasma and urine in people with endometriosis. So where are these phthalates found and what do they do? So phthalates will make our plastics more flexible. We find them in a lot of medical supplies, plastic wraps, beverage containers, toys. But important to people with endometriosis and the group of people that have endometriosis, they're typically listed as fragrance. So if we look at any product that we may have, and I, for instance, like looking at chapstick that I have, it has fragrance written on it. So none of these are necessarily regulated by our government, and they are listed simply as fragrance in color cosmetics, lotions, body washes, hair care products, and nail polish, and these are all known endocrine disruptors and immunotoxicants, and we find them everywhere around us. And so some of the studies that we've been doing is to try to understand what happens in the initiation of endometriosis when we're exposed to these phthalates that we're seeing every day from our floors to the products that we put on ourselves to the products that we may be used in the hospital, that our studies suggest that phthalates may contribute and make the development of endometriosis worse. Now, we don't have this published at this point, and we're in the process of trying to get grant funding for this to really understand what's happening in this initiation of disease. But I think overall, what this really brings to mind is a project that we've started to do for community engagement, is to try to explain the importance of some of these chemicals and that are in our environment. And one of the things that we had planned to do, and we made this before the pandemic, was to take this to schools in the area along with EndoFound's Empower program so that we could educate school-age children on endometriosis, what endometriosis is, but more importantly, where they could go ahead and try to eliminate or remove some of the bisphenols or phthalates from their diet, from their skincare products, from any types of products that they could potentially use. So the idea with this is we're happy to share this and get this out. If anybody would like to use this infographic for anything, go ahead and please email me again at the same email address, and we can send this out for your use. And I look forward to people using it, because we're unfortunate that we haven't been able to use it because of the pandemic. So with all of that being said, then I would like to thank the people in my laboratory and past members in the laboratory, our funding sources that happen through NIEHS, NICHD, through NIH, the University of Cincinnati, Endometriosis Foundation of America, of course, for supporting our preliminary data and studies with the phthalates experiments, and also then some funding we've had from Ferring Pharmaceuticals and the Center for Environmental Genetics. So with that, I will say thank you once again for the invitation to be here, and I appreciate your listening. Thank you.
Your explanation of the immune system and endometriosis helps us understand what occurs in both normal and endometriosis situations. Our next speaker is Katie Edmonds on endometriosis and blood sugar dysregulation. Ms. Edmonds is a nutritional therapist and a paleoimmune protocol certified coach. She is the creator of healendo.com and author of the 4-week endometriosis diet plan. She has 2 miracle children who followed treatment for endometriosis.
Hi, my name is Katie, and today I'm going to present on the link between endometriosis and blood sugar dysregulation. A little bit about me. I'm a nutritional therapist. I specialize in helping women with endometriosis specifically. I am creator of healendo.com, an online resource for everything holistic healing and endometriosis. I am author of the 4-week endometriosis diet plan, and I'm soon to launch my 2nd book, Heal Endo, all about endometriosis as an inflammatory condition. I got into this work because I myself suffered immensely from endometriosis for about a decade, the last 3 years of which were spent battling unexplained infertility. And it was during that time that I really started to implement some more strategic diet and lifestyle alternatives, most of which I hadn't heard of in association to endo before. And it was during that time, not only was I able to conceive, but I miraculously was able to put my endo in full clinical remission. And it was miraculous because I'd never heard that it was possible before. To me, it was magic. And it lit a fire under me to help other people do the same. I now have these 2 little cuties here. So it's kind of a testament that miracles can happen. I want to be very clear that diet and lifestyle are one tool in the endometriosis toolbox. They can help us immensely, some more than others, but endo is complex and it affects us all very differently. I'm still a firm believer that no matter who you are, you can have some dramatic gains through some certain types of diet and lifestyle alternatives. The one I'm going to talk about today is one I do feel that most people can benefit from, and it's regulating your blood sugar. It's something nearly all of my clients deal with. It's something I dealt with terribly, but few of us know what it is, even for those of us with clinical levels of it. So today I have 3 goals. 1, understand what blood sugar dysregulation is. 2, how it may directly influence endometriosis more than just symptoms. And 3, some action steps. I have 4 action steps I want you to be able to implement right after this talk without feeling like you have too much information overload. Our first goal, what is blood sugar dysregulation? So it's something you shouldn't have to think about. Our ancestors didn't, but what healthy blood sugar regulation is, it's just how your body keeps the levels of sugar in your blood, called glucose, very consistent and very low. It is something we take for granted, just how hard our body works to keep it consistent. And this is a great example that a healthy blood glucose level is considered about 5.7% or just a little bit lower. You get into a clinical disease range, not even a 1 percentage point above that. So by the time you're at 6.5% glucose, you have diabetes, which is terribly damaging in a lot of ways. If you're listening to this and have diabetes, you understand. And it's not even a full percentage point. Your body works very hard, again, to keep it low. It's why you can't go 1% over. Honey has 30% glucose. You know, it shows how your body does keep it always low. So this is how it works on a very, very basic level. You eat carbohydrates, which are basically plants. They break down in your system into a number of things. There's vitamins, minerals, fiber, water, but glucose is one of those things. And it is very important because every cell in your body eats glucose. Even if you're on an extremely low carbohydrate diet, your glucose levels are absolutely important. The only way to get glucose into a cell so that cell can eat is by pairing it with a hormone called insulin. Your pancreas is a little hormone, or I'm sorry, a little organ. It makes insulin, pairs with your glucose. And then at the very right-hand side here, I have the cell with a little insulin receptor. The insulin fits into it. It acts like the lock to the door. In goes the glucose. Your cells are fed. Everyone's feeling good. And that's exactly what a blood sugar chart represents. Exactly what I just said, except now we have the highs and the lows. So you eat food, glucose and insulin levels go up. And as they go up, your cells start to be fed. Your cells are eating, taking the glucose out, the insulin's dispersing, and the glucose and insulin levels go down. The reason why this is balanced blood sugar is because it never goes too low and it never goes too high. That's what blood sugar regulation is. It regulates it to keep in this very, very, very fine level. It doesn't act alone, though. It really depends on your diet, but you still shouldn't have to think about it. And that's because humans evolved over millennia eating a diet that really supported our body's ability to keep blood sugar levels very minimal. There's the trifecta, the glucose braking system, break as in slowing down, the glucose slowing down system. It's fiber, proteins, and fats. And some of our ancestors ate a lot more starches and sugars. Some ate a lot more protein or fat, but overall, none were eating a ton of just starches and sugars without any of this braking system. Unfortunately, we don't eat like this anymore. The standard American diet is what the average American eats, and unfortunately is based precisely around the foods we shouldn't be eating much of, if at all. And those are highly refined and processed carbohydrates, basically pure starches and pure sugars without the braking system. It's kind of assumed about 300 grams of carbohydrates a day, many of us not even meeting the minimum fiber requirement, which is 12 grams of fiber. And this is called a fiber gap. This is about 290 grams of a gap, which is absolutely enormous. It's something that will shove so much glucose into your bloodstream that your system goes a little haywire. But I want to talk about this other diet too. And this is where most clients come to me. They say, no more processed foods. We understand that it's really damaging to the system, but we're still not feeling very good. And when I look down at their diet charts and what they're eating, this is what I see: a diet really rich in starches and carbohydrates, sort of from juices, smoothies, yogurt bowls, acai bowls, lots of cereal. I'm gonna say quote unquote healthy desserts. So like the organic gluten-free cookies, vegan cookies, that sort of thing. And then lots of starches, grains, beans, sweet potatoes. So this diet is healthier, yes. There's more nutrients, yes. But when we're talking about blood sugar, it's doing the exact same thing, that it's spiking blood sugar levels, which leads to an imminent crash. So here we are. This is blood sugar dysregulation. The red in the middle, the good line, that's your regulated level that we touched on. You have the glucose braking system. You don't have to think about it. But secondly, you do have to think about it. Check out the blue line, the middle line. This would be like a blood sugar roller coaster as it gets going. You're not eating the braking system, so your glucose is flooding your bloodstream way too fast. You're in this too high danger zone, and your body absolutely hates it. So to get you out of the zone, it makes a ton of insulin. So you have lots of glucose and lots of insulin. It's so efficient that it actually pulls so much glucose out of your bloodstream that you fall into the too low zone. This is the zone of hypoglycemia, and we've all been here before. It's you're shaky, you're hungry. There's a word hangry that's absolutely perfect to describe it. It's hungry plus angry. Like you are so irritable, you are gonna, rip someone's head off if you don't get food, even though you just ate a few hours earlier. If this goes on too long, which it does for most of us, right? Like for years and years, you can develop more clinical dysregulation. That's going to be your purple line. This could be insulin resistance or prediabetes. Your glucose levels are being so poorly managed this time that you're shooting up way higher into the danger zone. You're staying there longer. Your dip is way steeper, and you're going back into that too low zone. Unfortunately, we eat like this throughout the day, and this is a visual of 3 meals. I don't know anyone who has serious blood sugar dysregulation who eats 3 meals. Usually it's more like 3 meals plus some snacks and sodas and treats at the end of the day. So this could be spiking numerous times. But I just want to get across that when we have a high and a low that's happening throughout the day, those hours add up, the amount of time we're in those danger zones. So it could be 6 to 9 hours that you're too high. It could be 2 to 6 hours that you're lower. You are going to be unique in this regard, but just internalize that we can be here for hours a day. That's many hours per week. And, it ends up being days worth of each of our years. Unfortunately, up to 80% of adult Americans do suffer from blood sugar dysregulation to some degree, some being very clinical, like prediabetes and diabetes, other having insulin resistance, obesity, highly associated with this type of blood sugar dysregulation. They're diseases of blood sugar dysregulation, as in it causes it. What I want to talk about is how it's associated with endometriosis, which is different. It affects endo rather than causing endo. So this is how it does. So there's 2 danger zones, right? There's the too high zone at the top and then the too low zone. I want to touch on the too high zone first. There's 2 things that are high, glucose and insulin. So when you have too much glucose in the bloodstream, it goes through a series of chemical reactions that create something called AGEs, advanced glycation end products, that little red dot. If you look at the little picture on the left there, each of your cells has a receptor called RAGE, and it's your AGE receptor. It's very aptly named because when AGE connects to RAGE, it creates an avalanche of free radicals. Free radicals are incredibly damaging. They just blitz cellular membranes at an incredible rate, which is really, really good if you have a bacterial infection or a virus that you want to get rid of. But when it's around your own healthy tissues and organs, it can be absolutely damaging. And this is called oxidative stress, the damage produced by free radicals. Now, very unfortunately, those with endometriosis have been found to have a lot more RAGE receptors at endometriosis ground zero. So I'm talking the follicular fluid, the peritoneal cavity fluid, and even within certain endometriosis cells. So if you have a lot of glucose making AGEs, it could be blitzing your peritoneal cavity, your pelvis, your endometriosis lesions every time it's too high. That leads to everything with endo we don't want, right? Tissue damage, chronic inflammation. If you're in that 9 hours a day category, it could be 9 hours a day of inflammation created by the AGEs. All of that tissue damage and inflammation leads to scar tissue adhesions and, of course, chronic pain. So insulin's a little bit different. And what insulin does is it stimulates your endometriosis to make some lactic acid. Unfortunately, endo makes more lactic acid than it probably should. So when you have insulin in high levels meeting your endo, it can create so much lactic acid that it produces a bit of an invisibility cloak. I kind of tried to illustrate here. It hides from the exact immune factors that should be removing it. So every day, your immune system should be taking care of really abnormal tissues, damaged tissues, odd cells, things that are misbehaving or shouldn't be there, like your endometriosis. But it's not. And it's one of the reasons how endometriosis is allowed to stay and progress in the body. It's part of the immune dysfunction we see. If you've ever heard that cancer feeds on sugar, it's the exact same mechanism at play. It's this lactic acid invisibility cloak. So in the same way, we could say that sugar feeds endometriosis. Okay, and then of course, after the high is the crash, you freak out at this point, right? You're shaking, you're hungry. For me, I would be so hangry. I wouldn't leave my house without snacks because your body has put you into a fight or flight response here. You are flooded with adrenaline and cortisol, which makes sense because your body is really freaked out that if you don't eat, you're going to have so little glucose you might faint. It doesn't want you to faint. So it has you do anything possible to get to food. Unfortunately, cortisol and adrenaline are directly associated with endometriosis establishment and progression. So this is a little different than saying, oh, stress makes us have worse periods. It's saying that these stress hormones actually are instigated in disease pathology. So they're really important to bring down. So there you have it. When we're on a blood sugar roller coaster all day, it really doesn't matter if you're eating the most organic, the most vegan, the most gluten-free, whatever, you're going to be on the same blood sugar roller coaster as someone eating a standard American diet. And it can be very, very damaging to everything with endo that we don't want, right? We have the pain, progression, scar tissue, adhesions, and even establishment. So it's the reason why blood sugar regulation absolutely needs to be part of any endometriosis dietary response. Okay, 4 tips to balance blood sugar. This can be as complex as we make it. There's tons of information all the time online. I think sometimes it's information overload. So these are going to be 4 really basic tips. And then I have to say that if you are on blood sugar lowering medication, you have to work with your provider at all times as you lower carbohydrates and balance your blood sugar to make sure that your medications are at the right level. So the first tip is, I call it really basic. For some, it will be a big challenge, and it's really just eat less processed carbohydrates. This is the easiest gain across the board. So these types of carbohydrates are contributing 60% of our calories for the average American and 90% of our added sugar intake. It is a huge amount. So before you worry about the minutia of proteins or fats or which carbohydrates, just try to move from the left-hand image to the right. This is a photo by Dr. Tyler Jean. He's phenomenal. He let me use his pictures for this presentation. But what I like about this one is that these are all gluten-free and organic for the most part. And I did this. I went gluten-free, and I basically was the left-hand side. I didn't feel that much better. And this was why. It was just so much sugars and starches. So it's something to take home if you also did that same transition. In the meantime, as you're getting there, learn to read labels. I said, processed foods, they give us 90% of our added sugars. And it's not like all of us are eating just sugar all day. It's actually hidden within even savory foods. So we have cereals, even really healthy, healthy organic cereals. They can have more sugar sometimes than Lucky Charms. We have pasta sauces, soups. It's in fake meat products, snack foods. It's hidden everywhere. So if you start to read labels, it's usually easy enough to swap out to another brand that's still there on the shelf. They're not necessarily hard to find, but they're going to be lower in sugar. And overall, you can lower your sugar consumption just by starting to read labels and doing a few swaps. Second tip. You want to stop the spike and slow the fall. So instead of, having the spike and then needing to keep spiking all day long to keep above that blood sugar dip, you want to never have it in the first place, which will then, slow the fall on the other side. So this is just a very basic example for people that have your meals are based around the starches, beans, rice, sweet potatoes, or, it's sweet meats. There's like teriyaki chicken and even sandwiches that are just stuffed with bread and extra sweeteners, sugars, anything on the side, sodas. Just move to the visual on the right. So you're not trying to cut out all carbs, but you're trying to lower the percentage of your plate that are carbohydrates. And I love, this is Dr. Tyler Jean again. Sorry, they didn't give him credit at the bottom, but it shows that even if you are vegan or ketogenic, there is a way to balance blood sugar that will keep you full and happy for, breakfast until lunch without a blood sugar dip. If you do need snacks, make sure to do the same. Don't just have an apple. Have apple with peanut butter. Don't just have toast with salmon and avocado. I saw on the back of a smoothie packet the other day, I was saying, make a smoothie with mango, banana, and coconut water. Absolutely don't do that. If you're going to have a smoothie, make it with low sugar berries, avocado, throw some zucchini or kale in there, and some protein powder, full fat coconut milk. I hope you're catching my drift of you just want that trifecta in there to slow down the whole roller coaster. Okay, basic tip 3, don't make it trendy. So in the United States, we have such a huge ability to see something that's bad and want to fix it so much that we swing our pendulum all the way to the other side to limit what damage it was causing. So in the case of blood sugar regulation, starches and sugars are bad. I might as well not eat any. And here we arrive at our, our keto, I'm not eating any carbohydrates and this is going to fix me, bacon, butter, that sort of thing. That's not what you want. So I have this, make your carbs count. And this is kind of what I want to be the drumbeat for also any sort of endo-supportive diet, that carbs are plants. Plants are giving you an abundant amount of antioxidants, which are absolutely essential to stop that free radical cascade. Okay, the only way free radicals are stopped, the only way is by pairing with an antioxidant. So if you're eating the bacon and butter, yeah, your blood sugar might not be spiking, but your inflammatory condition, which absolutely depends on a ton of antioxidants, is not going to be supported. So you're kind of fixing one problem while potentially creating another. So you want to make your carbs count. Don't make it trendy by just axing everything. Here you can see this plate. We have proteins, fats, avocado. I'm assuming those eggs were fried in maybe some grass-fed butter or olive oil. And then, yeah, you have, a cup of berries on the side. Last tip for today, and that's start with breakfast. Always start with breakfast. And that's because if you skip breakfast or you have a sweet or carbohydrate rich breakfast that doesn't keep you lasting for long and you get that immediate blood sugar high, you will never be able to balance it all day. It's kind of like a magic trick. You have to wait till you sleep to reset the system. So instead, start your breakfast with with something that's high in protein, fat, and fiber. I personally recommend, if you can tolerate eggs, some people are allergic, eggs and veggies are so easy. You can make them so many different ways before they get boring. If you want to add something like sweet potato or like a half a piece of toast to that, not a big deal. Again, it's all about balance. If you can't do eggs, I recommend something like a sausage skillet, something that is heavy in the veggies and protein. And again, if you can do it savory, it also helps retrain your taste buds for the whole day to not constantly crave the sweet flavors. When we eat like this, it goes back to staying blood sugar balanced zone, right? You're not on the too high, you're not on the too low. And that's what you want. That's just what balanced blood sugar is. It doesn't seem like rocket science, and it's not, but sometimes when we've been on the blood sugar roller coaster our whole lives, it seems crazy to think that we could get off of it. You can. I've seen many of my clients do it, and I myself did it. It can take time, so be patient with yourself. If you want more help, come check out my website, healendo.com. I talk a lot about blood sugar control. I have some ebooks on it. I also have the 4-week endometriosis diet plan, and it's everything I just talked about, but it also includes recipes and meals. So thank you so much for listening, and I hope this was helpful.
Dan, unmute yourself.
Yes, I'm unmuted now. Excuse me. So thank you, Dr. Burns. Oops, that was Dr. Burns. Thank you, Mrs. Edmonds. Your presentation on blood sugar regulation and dietary measures brings up points that are useful to all of us. Our next speaker is Dr. Tracy Haas on how to speak with your physician. Dr. Haas is a family physician working with the underserved and vulnerable populations around the world. She is an endometriosis patient who underwent several surgeries before receiving definitive treatment by Dr. Setkin. She is a clinical instructor with the University of Washington School of Medicine, a co-founder of Dr. Book MD, and a member of the EndoFound Board of Directors.
Well, thank you all for having me here today to speak again about pain and speaking to your doctor about endometriosis. I'm Dr. Tracy Haas. I'm a family physician in Laramie, Wyoming. I'm also a clinical faculty with the University of Washington School of Medicine, where I have the opportunity to teach first and second year medical students about a lot of different things in clinical medicine, but I always try to make sure that we're teaching about endometriosis early so that no doctor graduates from medical school without knowing what endometriosis is all about. I'm going to start by telling my story because I'm not just a physician who gets to work with patients and diagnose endometriosis, but also because I have suffered with endometriosis since I was a teenager. Unfortunately, and I'm sure like a lot of you can relate, I started having painful periods with my very first period. When I was 17, I went to the emergency room for the first time and was diagnosed with an ovarian torsion. I ended up having an emergency surgery at that time and was told that it was an ovarian cyst. It wasn't until 15 years later, with a lot of pain and a lot of suffering, that I found out that it was actually endometriosis back then. I was diagnosed in my early 30s when I went in for what we thought was an appendicitis, and it ended up being endometriosis. My general surgeon opened me up and ended up calling in an OBGYN because he recognized that it was endometriosis throughout my abdomen. He took out the appendix, but then, you know, as a lot of us find, a general surgeon is not the one who typically takes care of endometriosis. And so when he pulled in the OBGYN, they said, what do I do with the rest of this? And at that time, the OBGYN just said, we'll close her up and start her on Lupron. That was in my early 30s. And, you know, that's kind of the mainstay of treatment these days. And so I ended up having a lot of pain for the next decade, had multiple endometriosis ablation surgeries, and unfortunately had a couple of bowel obstructions, resulting in 2 major surgeries where I had bowel removed. So I only share this with you to let you know that I have a background that a lot of you can relate to. I hope that we get more women in for early diagnosis, earlier than I was. I had definitive surgery for endometriosis 28 years after I first presented to an emergency room for the issue. And my goal is to help patients understand what their symptoms are so they can present earlier. I also want to help teach physicians at all stages of their career how to identify endometriosis earlier so that we can help get women pain-free and cured, you know, with definitive surgery much earlier than I did. So I will touch a little bit more about my surgery as we talk more, but I was asked to speak to you all today to help you speak to your doctor. So because I come at this from multiple angles, from being a family physician, being an instructor of medicine, as well as being a patient. So let me tell you a little bit about how you should prepare in speaking to your doctor. So first of all, you have a relationship with your doctor, and it's based on trust and openness and honesty. And it's completely normal to be scared and embarrassed when you come in to speak about painful periods. And so I want to just first get that out of the way and say that it takes bravery. You are brave when you come forward and say that you've been living in pain, or that you've been nauseated, or that you're not able to participate in sports like you used to. Just know that that's completely normal and to be expected. Bring somebody with you so that you have a confidant, someone who can speak for you, because it's completely normal to show up in that doctor's office and go blank and say, oh my gosh, I can't remember why I'm here. So first of all, make an appointment and say you're there for painful periods. When you say you're there for a painful period, a physician is more likely to block out enough time for a full history and physical exam. It's really common for us women to minimize severe symptoms. And so I want you to plan on, when you're meeting your doctor for the first time, write things down. Your doctor is ready to hear your story. That's why we go to medical school. That's why we practice medicine. We want to help end suffering. We want to identify it earlier so that you get treated earlier. I want you to listen to your own intuition. If you feel in that doctor's office like you're not being heard, you're not being supported, it's okay to seek a second opinion. It's okay to ask for a referral for a second opinion or a third opinion. My hope is that you're able to see someone who listens to you and your story is heard that first time around, but it is not uncommon for your story to need to be repeated, or you need to be referred to someone that you feel really comfortable with. Keep in mind that there is a huge learning curve when it comes to endometriosis, and not every physician, you know, like me, has been through it and understands what sort of the ups and downs and the whole story are all about. So understand that, you know, doctors want to end your suffering. They want to hear your story, but they don't always have the tools. We're working on this. You know, EndoFound is certainly working on getting education and resources out to everyone who sees, you know, women as patients. But keep in mind that not everyone is at the same stage here. I mentioned that you should write down symptoms. There is a whole timeline that I love when my patients come in with like a huge stack of information. Don't be afraid to share your story with your doctor. That's typically really, it tells me that a woman really knows what's going on and is ready to tell me exactly what's happening, that you're involved in your healing process. So I want you to feel totally comfortable coming in with your history. And let's talk about what you should bring in. And I'll refer you to endofound.org website. There's a section preparing to see your doctor. I think it's got some fabulous tools there, in particular, a symptom tracker and a personal pain profile with diagrams. So you can write on the diagram where your pain is and when. So thinking through these questions prior to going in to see your physician really helps to organize thoughts and helps tell your doctor exactly what's going on. You know, there's stigma around pain and stigma around coming in and saying, gosh, I've been living in pain. We often minimize it, particularly if you arrive that day and you're not in pain and you say, oh gosh, I can't remember. I want you to have written it down. I want you to have on your symptom tracker and on your pain profile, mark locations of where the pain is and when and how many days and how severe. And severity of pain is also something that's really difficult to quantify. We, you know, historically use that 1 to 10 scale. It's really difficult to come in and say, wow, I had 10 out of 10 pain this day, this day, this day. And that's really common for endometriosis. It can be that severe. Most women don't come forward and say, oh my gosh, I've got a 2 out of 10 pain every day, right? We wait till things are pretty severe. And so don't be afraid to say that. The other thing you want to note is what have you tried to help with the pain? What's worked, what used to work and doesn't work anymore? Be really clear about medications that you've tried and how it helped or didn't help. What kinds of side effects of those medications that you've tried in the past. You know, be clear if something caused nausea or caused heartburn or caused dizziness, or you can take it and it helps the pain, but you're not able to work or drive. Those are all the kinds of things that help us help you when you come in to speak. The other thing about pain and the pain scale is that, you know, for many women, endometriosis affects jobs and hobbies and ability to participate in sports, and certainly affects relationships. So I really advise having this written down prior to going in to see your doctor, like the things that you feel like endometriosis keeps you from being able to do. You know, if it's affecting a relationship, these are some major things. This is no longer, here's a pain pill and good luck. This is quality of life issues that are really important to communicate well to your physician. So, so definitely take a look at our website and learn kind of what that personal pain profile looks like for you. And that patient tracker will help you organize your thoughts and your pain story prior to going to see your physician for the first time. It's also very important to gather relevant records. And just coming in with a giant stack of all your old records is one thing. And I'm not saying that's a bad thing, but if you could put things together in a Word document ahead of time and just really put down what your endometriosis related symptoms are, how they started, when they started, and then bringing in the list of medications that you've tried. So having that list of any sort of prior interventions, including any surgeries. If you've had a surgery, get your hands on the op note, so the operative note, so that your surgeon who's seeing you for the first time can see what's been done, what was seen, If you've had any recent imaging studies, bringing those, maybe not something remote, but something that you've had in the past year would be really helpful when you're seeing a surgeon for the first time. So don't think that bringing in materials are going to be annoying. They're not annoying to the right physician. The right physician wants to know what you've done, what you've tried, what has worked, so that we can get it right this next time. Another piece that I wanted to emphasize today is that, there is stigma around periods. And so part of addressing, how to speak to physicians and how to be a good patient, quote unquote, good patient, is that we need to also be destigmatizing having periods. And so part of my, passion and part of my teaching, both in my clinic or in my classroom, is that we need to destigmatize what's normal to girls and boys, to people really at all stages of their education, because I think that we begin to normalize pathology. And I know that for myself, growing up, talking about painful periods, it was very much indoctrinated to me that it was normal. This is just the curse. This is what women go through. And I had no reference for, what was normal pain versus abnormal pain. And so, unfortunately, I went through a lot more pain than what I now know is normal. And so the earlier we can talk about periods and pain and normal and pathology early on, then we can start advocating for each other. I think that this is something that should not just be taught to women and girls. I think that, normalizing this so that, brothers and fathers and boyfriends and friends can help, reinforce to a girl or a woman at any stage and say, wow, this is really not normal. So sooner that symptoms outside of the range of normal are brought forward, the earlier a woman will be diagnosed with endometriosis. Another piece around this stigma is shame, and it becomes really difficult to overcome that shame, particularly when it's reinforced that pain is something that a woman should sort of suck it up and push through. So please know that the quiet suffering that happens with women in when they're suffering from significant pain like this, it's really common, and it's something that we need to shine light on and say is not acceptable any longer. We cannot allow this quiet suffering. So please, come forward and bring your symptoms forward. Another piece of shame and stigma is that endometriosis symptoms often involve bowel symptoms. Sometimes you are, having nausea or diarrhea or cramping, or in my case, when I had bowel obstruction, I couldn't go to the bathroom for several days just because I had such a, distended, painful abdomen that I wouldn't eat for days on end. So those are important symptoms to let your doctor know, even though it's uncomfortable to talk about going to the bathroom or not going to the bathroom. I think that's something that we need to be clear, like, okay, 5 days prior to my period starting, I don't eat. And it's not because I'm nauseated, it's because I know that if I eat, I might have to run to the bathroom in the middle of a meeting or at a sports event or on an airplane. So be okay with speaking about things that are traditionally shameful or stigmatizing or embarrassing. That's really what your doctor is there to hear and help you with. So I also want to talk to you about how to write down and sort of quantify symptoms that aren't pain, because this is also really important to bring to your doctor. When it comes to endometriosis, often women have symptoms that start before their period or may last throughout the month. And so keeping a log of timing in your cycle of when you're having symptoms like nausea or bloating or a distended abdomen, if you're having constipation, diarrhea, all of these things can be really difficult to talk about. Many women think that they shouldn't talk to an OBGYN about diarrhea, or they shouldn't talk to a family physician about periods. We all are here to listen to all of it. And a really important piece of sharing these kinds of stigmatized pieces of your story are to explain to your physician how they impact your life. If you're a person who travels for a living and you're starting to change your travel schedule or your work schedule so that you don't have to, get on an airplane because you're worried about a symptom that might pop up unexpectedly. If you are, into sports and you're starting to cut back on your involvement in sports because you're having symptoms that, again, aren't just pain. This can be all kinds of bowel, bladder, fatigue and nausea, which are really common hallmarks of endometriosis. These are the kinds of things that we physicians want to hear about and you should be bringing forward. Keep in mind too that endometriosis isn't just something that involves your uterus. This can be pain that's in your hip. It can be, pain that hurts when you take a deep breath. You may have pain on one side or another. So make sure that you're able to explain all the different things, even if you're not sure it's endometriosis. Just tell your physician what is happening and how it's affecting you. Another big piece of endometriosis is infertility. And so if you are a woman who has been trying to get pregnant and been unsuccessful, that is a big part of this that I want you to feel comfortable bringing forward to your physician. So, just to wrap things up, I want to just kind of review. Number one, your relationship with your physician is based on trust, openness, honesty. And if at any point you feel like you're not getting that, don't be afraid to look for a second opinion. Second point, physicians are here to help you. They are committed to ending your suffering. And so don't be afraid to share what suffering is for you, and understand that sometimes a pill is appropriate and other times it's not. Part of having a trusted relationship with your physician is that it is a two-way communication, and your physician will listen to you, but you should also listen to them and understand that they need to hear your story to make the right diagnosis and also come up with a treatment that isn't just a Band-Aid. It's something that is a long-term treatment for you. So when you come in, keep an open mind. Sometimes a pill is appropriate, sometimes a surgery is appropriate, sometimes some other modalities are appropriate. And so just keep an open mind there. If you don't feel heard, you can get a second opinion, but keep in mind that they are there to help you and there to listen to all of your symptoms and your entire story. And third, prior to that appointment, gather your materials, be prepared, be organized, have a timeline, have any operative notes, have your medication list, and let them know what has worked, what hasn't worked. If you have a family member with endometriosis or with pain, if you have any family history, bring that information. It's extremely helpful when you sit down to speak to your physician. So, in closing, I want you to know that going to your doctor with this story takes bravery. So I commend you in, gathering information today, getting prepared. I also hope that you advocate for other women who might tell you that they're having pain with their periods. And we're all in this together. I think this is going to take an entire community approach. So medical community and, every boy, girl, man, woman out there, it's going to be really important for us to take a whole community approach to helping identify and treat endometriosis earlier. So thank you. Well, thank you all for having me.
Okay, I'm gonna learn. Thank you, Dr. Haas. As always, your comments are useful not only for sufferers from endometriosis, but also for anyone seeing physicians. Our last speaker will be Dr. Laura Payne on coping with the stresses of pain. Dr. Payne is director of the Clinical and Translational Pain Research Laboratory at McLean Hospital, Harvard Medical School. She has numerous grants from the NIH, including a career development grant to examine central pain mechanisms in adolescents and young adults. Dr. Payne.
Thank you to everyone at the Endometriosis Foundation of America for inviting me to present today. I feel very honored to be able to share a little bit of my research and clinical experience, and I'm so happy to do so. So as I'm sure many of you know, endometriosis has a huge impact on women's lives. It's often associated with chronic and severe pelvic pain. And this seems to be one of the main factors that it contributes to difficulties in mental health, including depression, anxiety, and lower quality of life. We know that half of women with endometriosis experience significant impairment in work and relationships. And of course, that contributes to depression and anxiety as well. But we do know that pain is a really important component of this, even though endometriosis obviously has other effects as well, but it's the pain experience that seems to really be associated with mental health difficulties. So one of the questions that you may have, and I think that many people have, is that why do certain women experience more pain than others? And this really has been the big question in all of pain research for quite a long time. And what my research is looking at is trying to understand that. Why do some women have more pain and more impairment than others? So to illustrate what we know about pain and what our current understanding of pain is, I want to show a slide that describes or that illustrates this. Would you be able to enable the screen sharing? Okay. Here we go. I think, let me see here. It is not picking up on my, I'm going to try this again here in just a moment. So what we understand about pain is that the entire experience of pain takes place in the brain. So many of you may have experienced physicians or friends or family members who say, you know, your pain isn't real or it's all in your head. And this is really not how we understand pain at all. Because whether you have cancer, whether you have endometriosis, whether you have broken bones, everybody has a different pain experience because there are so many different aspects of our experience that contribute to our own experience of pain, only one being signals from nerves. So when we get some pain signals from nerves, it travels into the brain. And that information is processed along with our own beliefs about pain, our expectation about whether something's going to be painful or not, our expectation that we're going to not experience pain, which is kind of a placebo. It determines our hypervigilance, whether we're attending to the pain, whether we're distracted or worried, also our mood, and different aspects of the chemical and structural aspects of the brain. So all of this information, along with the signals from nerves, determine what our experience of pain will be. And this really helps us understand why people experience pain in different ways. And we know this from our, probably just everyday life, that some people just, they can, get into cold water and it doesn't bother them at all. And other people are very sensitive to it. And this is actually one of the tasks that we use to evaluate pain, is putting a hand in cold water. So having this understanding about how pain works in the brain allows us to then use and develop other ways of coping. And of course, because pain causes impairment in life, that is associated with depression. We also want to avoid pain. And so that can lead to anxiety, But what's another important component is that the pain pathways that in the brain are very similar to the pathways for depression and anxiety. So even on a neurobiological level, there are a lot of similarities there, and it makes perfect sense why somebody who experiences pain would also experience some of these other mental health issues. So the question is then, what can we do about it? Well, chronic pain often requires a multidisciplinary approach, and this can be true for endometriosis as well. Obviously, medical interventions and having a physician that is very attentive to your needs and providing the appropriate care is essential. This could be surgery or other procedures or medications. We also know that physical therapy, often focused on the pelvic floor, can also really help with pain, and finding a physical therapist that specializes in pelvic pain can be a real help to help strengthen certain muscles and alleviate at least some pain. And then, of course, there's psychotherapy and other mind-body interventions. And I'm going to talk a little bit more about these different options. But all of these different types of approaches are important, and not one is going to be the complete answer. And so finding the treatment approaches that work for you and help alleviate pain and then resulting mental health struggles can be so important. So there are some treatment interventions that are done more on a consistent basis. And these aren't things that you would do and expect to feel immediate relief. But these are things that over time can really be helpful for managing pain, and we know this from clinical research. This includes meditation and relaxation. It's been one of the most widely studied interventions, and not only benefits pain, but also benefits depression, anxiety, and worry. Also, yoga can be a very beneficial practice. Again, it has impact on pain and mental health issues. I think the most important thing is finding a practitioner that is trained in pain conditions, because when you're in pain, you need to have somebody who really understands exactly what is happening in the body and would not put your body in a position that was going to cause additional pain. We also know that even communicating your emotions can have an impact on pain and depression and anxiety. So if you're struggling on a particular day, being able to communicate that to somebody who's supportive, whether it's a partner, family member, friend, or even just in the endometriosis community, can actually really help alleviate some of that pain. Exercise is very important, but there's a caveat to this in that, as with all of the activities that may be helpful for pain, what's really important is that you don't overdo it. So there's this important concept that we call activity pacing. And that means on each day, determining the level of activity that is appropriate for you and that isn't going to, you're not going to push yourself so much that you're in additional pain. But that's something that you feel active and engaged in, but not pushing yourself too far. And so it's really also trying to understand that for yourself, like where is that limit? We also know that massage and acupuncture can be helpful for pain as well as depression and anxiety. And of course, different medications prescribed by a physician that really understands pain can be a tool. So there are many different tools that you can use that will address the pain as well as some of these other mental health issues, because we know that mental health is so closely tied to the experience of pain. I'll also speak a little bit about cognitive behavioral therapy, because that's what I do. And that's a type of psychotherapy that is a little different than just a regular talk therapy. It's more present moment focused, and it's skills based. So usually at each session, you're learning a new skill, learning how to apply it to your experience, and then practicing the skill in between sessions. I don't have time to go over every detail about it, but the essence of cognitive behavioral therapy is first really understanding the relationship between your thoughts, your feelings, especially your physical feelings in your body, and your behaviors. Because we can see how if you may think of something in a very kind of negative way, that's going to affect how you feel physically, and it's going to affect what you do behaviorally. And so trying to understand that relationship will help you begin to shift some of those different things. One of the coping strategies that we could just generally call healthy thinking is trying to identify some of the thoughts you may be having, either about pain or just in general, whether they're negative, anxious thoughts. So identifying what you're worried about or what you're thinking about that's negative, trying to look at the evidence in your experience to see if that is accurate. So if you're worrying that, you're feeling, kind of a pain flare up, and the thought might be, well, this is never going to get better, right? That might be a common thought that people experience. You can take a step back and say, okay, well, how many times has this actually happened to me? And has it always stayed at that level? Or have I gotten better? Even if it's not pain-free, have I been able to come back from that? And usually the answer is yes. So you can help challenge some of those thoughts. And then you can also consider how you would cope with this kind of worst outcome in your mind. Like, what would you do? How would you cope with this level of pain that you were experiencing if it persisted for days or even a week without any relief? What are the ways that you could get support, even if you couldn't change the pain? And separate from that, we know that distraction can help with pain, at least in the short term. And identifying and dealing with life stressors can also help. This is not something that can be done immediately, but if you find yourself, there's a stressful aspect of your job, or there's a stressful aspect of a friendship or relationship, trying to work on and changing those stressors so that you have overall less stress in your life can be helpful. The last thing I want to share is just a slide that has just a few resources on it. One second here. So these are two professional organizations that I am a member of and I'm very much involved in. The International Pelvic Pain Society is a wonderful group of both treatment providers and researchers focused on helping alleviate pelvic pain, primarily for women, but for men as well. And on the website, you can find a lot of information, as well as it's a small referral database, but providers from physical therapists to psychologists to pain physicians that may be in your area. And it's a really useful website. And the second one is the Association for Behavioral and Cognitive Therapies. This organization is focused on promoting cognitive behavioral therapy and really getting the information out there to people who need it. And so there is a lot of information on there for pain, for depression, for anxiety, lots of different types of anxiety. And also there is a Find a Therapist referral database there that you could explore for somebody that may have expertise in what you are looking for help with. And that is my presentation, and I'll turn it back to you.
What is a good way to handle feelings of guilt and shame that can be associated with having endometriosis? And what impact will it have on the desire or ability to be intimate and eventually have children?
Yes, I think guilt and shame is an emotion that comes up a lot, especially for women when they are limited in some way in the role that they've expected for themselves or that other people expect. I think using some of the healthy thinking strategies can be helpful for challenging that guilt and shame. You know, guilt signals that we've done something wrong. And is this really a situation where you've done something wrong? Or is this something that you're also struggling with and, you know, wanting to improve? Because if, you know, in that case, the guilt would not be an adaptive emotion in that situation. So we'd want to challenge it. But I think, again, going back to communicating, especially with partners, this is such an important thing to do, especially when you're struggling, you know, either with intimacy or, you know, potential fertility issues down the road. Having this good communication with your partner and also being receptive to what they feel, it can really help. I can say that for sure.
How can you specifically address psychological factors and through CBT that contribute to pain? And I think maybe just a little bit more of a general description of CBT would be helpful as well.
Yeah, right. And that's, I think, one of the primary ways to address those other factors is through cognitive behavioral therapy. So cognitive behavioral therapy often involves learning a lot more about what your experience is. And that includes the thoughts that arise when you start to experience a painful sensation, or when you experience a stressor, or, you know, something kind of triggers an emotional reaction. And it's understanding your thoughts, how those thoughts impact how you feel, and then what you do as a result. And throughout the process of therapy, you're working to try to change kind of each of those components. So, you know, working on challenging those anxious or, you know, very negative thoughts using some of the strategies that I mentioned, working on the physical sensations, and that could include through exercise, through stretching, through relaxation, whatever the tool is that ends up working for you. And the point is to experiment to find what works for you, because not everyone is the same. And then it's also working on the behaviors. So oftentimes when we think very negatively, or we think like, I'm going to go out and it's just going to be terrible and I'm not going to have fun, we would want to stay home. And we work on challenging those behaviors and trying to engage in new behaviors. So in that example would be going out, or at least going out for a little bit of time. And again, that's the activity pacing. You can't push yourself too much. But that is how cognitive behavior therapy actually does change some of those pathways, and why it's so important to include these other complementary treatment approaches when you're dealing with chronic pain.
Thank you, Dr. Payne. Coping skills are needed by anyone with a painful condition and are particularly useful for sufferers of endometriosis. We're going to continue now with questions from the audience. The first is an administrative question for me. Why can't I see responses to the questions this year? Generally, Jean or I sit in the background and answer those questions, but Jean is not available today, and I'm handling 8 different windows right now and couldn't even try to do that. Anyway, we will try to have that ready for the next session. In the meantime, we're going to come back to the other questions. First one I'll have for Dr. Second. What kind of symptoms occur when endometriosis is outside of the pelvic area?
Well, of course, the question outside the pelvic area, that is, if we consider appendix and higher bowel lesions, which are really not that common, small intestine obstruction, but most of the there are bowel-related symptoms from ileocecal area and appendix, that's right side. Many of the bowel-related issue is generally vagus nerve issues, and that's gas, bloating. If it is large bowel, constipation, If it's ileocecal area affected, more diarrhea because there's water is absorbed there and they have more diarrhea. That's bowel related. Certainly chest pain may be important, yet chest pain, we have a large series of thoracic endometriosis. Chest pain itself is not an indication for any high, valuable sign for thoracic endometriosis. But shortness of breath during periods is significant. If there's hyperventilation, shortness of breath, and sudden pain during period, that's called catamenial pneumothorax. That is the most significant symptom, and thankfully, luckily, it's not a very common complaint. Obviously, during the menstruation, pain at the belly button, a mass there at the belly button, palpable mass at C-section scar get tender during period time, or inguinal area, or sign of endometriosis at those areas. That's all I'm going to say. Really, most common extrapelvic endometriosis appendix and ileocecal area, and then probably diaphragm endometriosis is very common, but usually is symptomatic, is a part of ruptured endometrioma. But transdiaphragmatic endo in chest obviously have more other symptoms than just pneumothorax or catamenial pneumothorax. Thank you.
Thank you, Dr. Setkin. Our next question was asked in an earlier session for Dr. Isaacson. He is now with us, and we're glad to have him in attendance. The question was, I was diagnosed with adenomyosis prior to having a hysterectomy. During surgery, a great deal of endometriosis was removed. However, I'm 2 years post-op and still deal with symptoms. Should I have my ovaries removed too?
And the answer to that really depends on, well, first, the easy answer is no, the ovaries don't need to be removed. The second answer is you still have the uterus, which has the adenomyosis in it, so it's not surprising that the symptoms would still be there, since that's not treated with laparoscopic surgery. And how you treat it really depends on the desire for future fertility. So if the best treatment for adenomyosis for women who would like to preserve their uterus for future fertility is typically a progesterone secreting IUD. It works about 80% of the time, and about 20% of the time it has to be removed because of side effects.
Keith, I think she had hysterectomy.
I thought she
had her
said
uterus removed.
What's that?
I think her uterus is removed, and she says she's asking whether her ovaries needs to be removed or not.
Not if she says she has adenomyosis, and then you've already treated the adenomyosis by removing the uterus.
Yeah.
So I miss it. Dan, you can clarify the question, but it sounded like the uterus was still there.
No, she originally had a hysterectomy, and they incidentally found endometriosis. All of that was removed, and she's still having symptoms. What would be the next step?
The next step. Yeah, then I think some not necessarily removing the ovaries, but I would do a trial of suppression of the estrogen to see if that's going to help with the pain. It can be done with something like Orlissa, which is a GnRH antagonist, or it can be with a progestin to see if it will be. I would do that before I'd remove the ovaries, because obviously once the ovaries are gone, you can't put them back.
Let me add to that and extend that out to Dr. Haas. What are some other non-surgical alternatives to pain management? Many women don't want to become menopausal. What do you think of Depo-Provera?
Thanks, Dr. Martin. To answer the last part of that, what do I think of Depo-Provera? I think it's a great
medication for some women, not for all. And so just like all of these treatments, I think you have to really guide, what you're treating and why you're treating it. So I would say I've had luck with some women suppressing some of their symptoms with Depo-Provera. Certainly has some side effects that makes it not the right medicine for everyone. We're lucky to have great new medications, as Dr. Isaacson just mentioned, or Alyssa, as one of our newer GnRH antagonist medications. So as I mentioned in my story before, I was on Lupron for about 10 years. You don't have to do that anymore, which is wonderful. So there are some great alternatives, various medications, like Depo-Provera that inhibit your pituitary gonadotropin release is going to help with suppressing that kind of growth of more endometriomas and the endometriosis as it sort of develops out over time. And still, anti-inflammatories are great medications. So, a lot of women do get some pretty decent suppression in pain from, the right types of NSAIDs and other anti-inflammatory modalities. I'm a big fan of anti-inflammatory diet. And there are some supplements that have been found to be helpful in some women. So I'd say just work with your doctor or doctors and come up with something that's tailored to you.
The only thing I would add to that, Dan, is if you're going to try Depo-Provera, try the oral progestin first, or even oral Provera, because once you try the Depo-Provera, if you have side effects, it takes a long time for that to get out of your system. But if you try the oral first and then you're very happy with it, then you can convert to the Depo. So you only need an infrequent injection.
Yes, Keith, I frequently found that was correct. I had patients who were very sensitive to progestins, and we actually started something like medroxyprogesterone at a fourth the normal dose. We had to break pills in quarters.
Right.
Because they'd previously had reactions, and we started out at a tremendously low dose to try to build up to make sure that they didn't have significant problems related to using it.
Can we just dig on this question? This is an important subject. So I like to interject someone said, as you know, these twins told all of you that I was a cut-happy surgeon, but the issue is here, let's separate management and treatment. If it's endometriosis and it's not responding medical management, it needs surgery. Most likely there is not enough endometriosis removed. So that should be in mind. So we need to really separate management. None of these drugs get rid of endometriosis, period. Let's make that clear for everyone. They are management issues. They manage the symptoms. So endometriosis doesn't disappear suddenly because of these medications. So to answer that question of that patient, my take would be most likely there is incomplete removal of the endometriosis. Probably it depends what the symptoms are. And it is there somewhere. The symptoms really tell you where to look for and where to hunt endometriosis. Thank you.
Thank you. Let me ask you another question. How do you detect, or can you detect, peritoneal endometriosis before surgery if it does not show up on imaging?
Well, you can't detect, but there's a high presumptive diagnosis based on patient's symptoms, the cardinal symptoms, and how long they've been really direct you to high suspicion. What are the cardinal symptoms? Severe dysmenorrhea that is lasting more than 2 days, patients out of commission, quality of life worse, and it is now throughout the cycle, pelvic pain. General systemic findings, pain with intercourse, pain with constipation, especially flaring up during period. So those could be without deep endo, without endometrioma. They could be as well all symptoms of peritoneal endometriosis. So high suspicion, patient insisting on their symptoms, and a doctor who is experienced listening to them. That's presumptive diagnosis. There's no other way. Definitive diagnosis is by laparoscopy. Real definitive diagnosis is by histology under the microscope. Unfortunately, if peritoneal endometriosis signs do not respond to medical management and the quality of life is decreasing, I think there's a place for surgery, timely surgery, without delay, and without jumping on early to the case?
I think we may look at that a little differently, but that's what's so nice about having this conference. I think if it's dysmenorrhea, then the disease is probably in the uterus and not in the peritoneum. I think the peritoneum can cause other symptoms, but it's not going to cause the uterus to cramp. And that by definition is what dysmenorrhea is. I think also when you have painful intercourse, that could be from peritoneal endometriosis, but it could also be from a very inflamed, sensitive uterus, depending on the uterine position. So it's not, I think we have to think of both now. It's not just peritoneal disease, it's peritoneal disease and probably even more commonly adenomyosis, which is uterine disease, because 80% of patients who have pain from endometriosis have severely painful periods, which I think is uterine disease. But well, time will tell. That's my input.
Great.
I wanted to ask you guys also, because do you believe also that peritoneal disease causes more nausea, more bloating, particularly after a period?
Mm-hmm. I don't know if it's peritoneal disease or if it's bowel disease, which makes sense.
Yeah.
That also depends on whether it is pure peritoneal disease or whether it's fibrotic. There was a slide that we had at the meeting yesterday, which is here. If you look at that lesion in the middle, that is an 8 by 8 by 2 millimeter lesion. It is peritoneal. It doesn't make it to the ureter, which is sitting right behind it. That disease does not cause that disease does not cause diffuse pain. That one causes generalized pain. Excuse me, that one causes focal pain. So if you get a dark scarred lesion like this, the patients can actually point to the disease. You get more generalized disease when it is more on the surface and it's not encapsulated. And I don't have a ready picture of that right now, but it looks like little pebbles on top of the peritoneum. So the ones that we showed in the earlier presentation. So when Dr. Setkin talks about peritoneal disease, that includes things like this. I'm not sure that really describes exactly what this is so much as some of those other ones that we showed earlier. So it becomes a very interesting research question. Now let me see if I figure out. There we go. Back to everybody. Back to the thing. So it gets interesting in terms of how we're going to look at these different sections. Let's go to the next one. So peritoneal. So does anyone want to talk about on the pathology report, which shows 50% estrogen receptors and 90% progesterone receptors in a retroperitoneal nodule? What does that change? How does that change what you're going to do, or should that change what you're going to do? In my mind, that's a research question. Does anybody have a clinical answer for that question?
No, we don't routinely check estrogen and progesterone receptors, so I don't know how it would change our approach clinically.
Pamela, do you have any experience with receptors outside of research?
Well, we never look for receptors, but generally, if it's a nodule and if it's removed, wonderful. But if there are more nodules left, that's another question. These endometriosis is known to be progesterone resistant, and inherently these cells also have a capacity of producing their own estrogen. So 50%, I don't understand the 50% receptivity. That means the rest of the endometrial glands are not receptive negative. This is not breast cancer tissue. It's not weighed in the same way. This is a very unusual question, but it needs to be explored. I never was asked this kind of question before. I don't know the value of it. Endometriosis is an estrogen-dependent disease. If there's no estrogen, endometriosis would not go forward. That's the essential pathophysiology that really cause progression of endometriosis. Thank you.
So another question. There are lower natural killer cell counts and increased neutrophils that are indicators for infection. What are the links between endometriosis and infection, and what cultures do you think should be done in endometriosis patients or any pain patient?
I don't know who wants to take a stab at it, but they're just starting some new studies to look at the relationship of the normal and abnormal microbiome, the vaginal microbiome, and its relation to endometriosis. But those studies, that's very different from an infection. It's like, what are the normal bacteria that should be there, and in what circumstances is the normal bacteria altered to allow for potential for endometriosis? So that's a very early research question, and I don't know what will come of it. But people need to understand there's a big difference between inflammation and infection. So you can certainly have inflammation, which is seen, signs of that are seen as described there with your natural killer cells and what have you, but that's not necessarily from an infection. So to my knowledge, I'm not aware of any infection that has been related to endometriosis or adenomyosis.
I mean, nuclear material being exchanged due to dying cells and microbiome related nuclear material getting into from bacteria is something they are trying to describe or find cause with, relation with epigenetic aspect of the endometriosis. There's a trend. We know that these are all clonal cells from endometrium. However, there's epigenetics aspect of it, that new nuclear material change the course and the attitude of the cells based on stem cell related inflammation. This microbiome thing is heavy now, especially with IBS symptoms, not necessarily from the vagina, from gut also coming in. It's all SIBO. I personally, it's hard to, like Dr. Isaacson said, we have to differentiate between infection and inflammation. If there was infection, this is the 30 years ago, it was all pelvic pain, was chlamydia, gonorrhea, herpes, this and that. We all with prejudice, we thought that these were all PID, and all these women were all treated as PID with no culture positivity. In fact, we learned that this was endometriosis later. So we have to be very careful. There's a trend going on. I'm watching it very cautiously, trying to read, but I think the jury is out there, and I'm not in that league yet to accept the microbiome effect of DNA exchange. Honestly, I'm not.
Okay, so we have a question that we want to go to the most popular questions. I can't see those on my screen, but here comes one. They're sending them to me. Why does endometriosis cause pain in some women, but not all?
That's $1 million question. I wish we had the answer to, which we don't. There's lots. Everybody who's going to give an answer, it's nothing more than a theory. We have started to look at various things, particularly in patients with the adenomyosis, which you can see increased nerve fiber growth in the areas where the lesions are present, at least in the uterine muscle. And that's been shown as well in the peritoneum. That's probably one mechanism. Another mechanism has been suggested, has been increased release of prostaglandins. The entire inflammatory mechanism can also cause pain. But what's more interesting is why some people have severe endometriosis and have no pain. So again, all the theories we come up with certainly doesn't explain the symptoms for all patients.
Okay, and then another one of the upgraded questions. Have you looked at dioxins in relationship to endometriosis, immune and hormonal disruption? Let me start that, because I published a paper in 1992 on dioxins that when we were looking at the rhesus monkeys up in the primate center in Madison, Wisconsin. And we showed that really severe endometriosis was found in that group in a dose-dependent fashion in the monkeys who were exposed to dioxin in an Environmental Protection Agency study. But that was a retrospectively identified population. There were two parallel populations. one in I think Oregon. I don't remember where the third one was. They didn't find it in those two, and those were parallel populations. We had identified ours because somebody on pathology noted that one of the monkeys had died with severe endometriosis, and that was picked up by Mary Lou Baldwin of the Endometriosis Association, and she had done that. Since that, there have been multiple studies on endocrine disrupting chemicals, dioxin, etc., and there is really a mixture of findings. There's no absolute answer to that question. There's a good chance that has something to do with it, but I don't think we can define exactly what it's going to do. Let me ask, here comes a very relevant clinical question for patients who related to insurance coverage and everyone else. I'm not sure we've got a good answer, but let's try it. What advice do you give to people who could not afford to pay $800 per appointment with a private physician? How do you go about finding a doctor?
I can take a stab at that as a primary care physician and a non-surgeon, because I get faced with this question quite a bit. And, and it's tricky, right? I mean, we have, healthcare access issues across the country for a variety of reasons. My advice to women when we know we're looking at a surgical intervention, I really do work with them on getting insurance. That is one of our just best things that you can do. And you've got, a lot of different types of physicians who can help treat, it's not always a specialist. I ideally get you to a specialist if we can, but there's a lot of different ways that you can initially address endometriosis. But I do work with women to find ways that we can get them health insurance, and that's kind of a great starting point for them.
I like to address this question because we are in private practice professionally, but the foundation has a fellow now. We're trying to create a system that at least we screen some patients who are in dire need for surgery and identify who would qualify for it. It's not easy because we don't have physical means of doing this, because there are so many things I cannot explain to you. But I personally think whoever that is asking that question, I left my email there. Please write to me. I will see you personally. I will help you with no charge, whatever I can do. Yet I cannot promise surgery, but we have to see how it goes, and you have to understand that. Other than that, we as a foundation, we've been trying to solve this problem. Unfortunately, the overall everybody's financial means are different, and best thing is to at least to have a basic insurance. If there's a need for surgery, hospital is compensated, because we can't just, I don't have any power to make things happen through the hospital, but we do waive surgery on certain patients based on their requests and clinical status. Thank you.
Okay, let me see where we are. I had a question here and I've lost the question. Let me find it. There it is. So, why does gynecology consistently delay endometriosis diagnosis until someone tries to get pregnant? I want to share a recent article on that, which was Diagnostic Delay of Endometriosis in the Netherlands. This is similar to what I saw in practice, and I think these data are fairly clean. But if we look at that study, we have two different things. One, infertility patients were diagnosed more rapidly than pain patients. They had an average diagnosis to infertility in 1.75 years, and average to pain in 8.33 years. That may be related to the fact that infertility is seen as a disease and pain is normalized and seen as a normal condition. But the second part of that question was, where is the delay? The median delay is about 7.4 years. And if we look at that, the gynecologist and patients are part of it, but getting them to the gynecologist is a more major problem. So the screening process is our more major one. And I think that in the long run, we have to have programs that are designed to help educate pediatricians, family physicians, internists, and everyone else in primary care to do this. We can't just focus on gynecologic surgeons like the ones who are going to be seen in the 4th week of this program. We've got to get back to primary care to do this, because not everyone is as attuned to this as Dr. Haas and others who've been involved in it. Tracy, do you have any comments about that?
Yeah, I do. And I really like that study because I think it highlights kind of where medical education is. I know when I was in training, it was, you're really thinking about endometriosis when someone presents with infertility, where pain could be anything, right? And so we just didn't kind of narrow down, a diagnosis or even necessarily have that high on our radar of suspicion when it was pain alone. And so I'm not surprised by seeing that, but I hope that this changes and certainly decreases that time frame from, someone presenting in pain to diagnosis. But I think it's going to take medical education. We're talking medical school education level, and then continued on into residency. I would add gastroenterology as a specialty that I would like to increase kind of awareness. In my practice, I would say in the past 5 years, I have more women that are presenting with pretty significant IBS symptoms that have gone undiagnosed as that's actually due to endometriosis. And once they have a definitive surgery or an excisional surgery, their IBS symptoms disappear. And I've been seeing that maybe with increased frequency. I don't know if it's because I'm tuned into it more or I'm just seeing more women presenting in that way. But I think the more we put endometriosis on the radar for diagnosticians, no matter what their specialty, I think we're going to start diagnosing it earlier and earlier.
If I could
I have a comment to make. Okay.
Just one comment on that, 2 comments on that. One is, this gets back to not just physician recognition of endometriosis, but also for funding for research in endometriosis. The NIH funds, it has very, very little funding for women's health overall, and almost zero funding for women's health that's not related to breast cancer or ovarian cancer. It's 1/10 of the funding that urologists have for male disease. So that's part of this whole problem of things not being recognized. And 2, there is a learning curve that just takes a long time. We just now started a study on college students just who have very painful periods to look for signs of adenomyosis, because we always thought that was a disease of women in their 40s. And I'm talking about, these are well-seasoned gynecologists who we always have been taught that it was a disease of women in the 40s. Now we know it's actually in teenagers. So this is a learning curve. It does take time, and it's going to take time, as Dan said, to educate not only primary care physicians, but clearly the pediatricians as well. So we'll get there. But like all these things, they take 10 or 15 years to change people's habits.
My comment on that is with respect to fertility specialists versus gynecologists. On fertility aspect, the situation in the Netherlands is totally different than the situation in the United States. Netherlands have a social medicine going on, and it's another world where endometriosis is spelled very easily. In the world of fertility, so many people are pooled there. They are not even, they don't even know they have endometriosis, despite they may have serious endometriosis going on. They never, ever ask patient symptoms, ever. I've never seen a very rare fertility specialist really after going after the inflammatory effect of endometriosis causing infertility, unfortunately. And millions of people, if not hundreds of thousands, are pooled in that category. That really, the high prevalence of endo is squeezed there that we don't see. In my opinion, of 30 years, I'm seeing that kind of population. Thank you.
Okay, our next question is going to be the endo belly question. I have bowel endometriosis and I'm waiting on surgery. I have constant distension of the lower abdomen. What could cause this constant distension?
Well, obviously, bowel endometriosis, anything without deep endometriosis, any miliary multiple endometriosis of the peritoneum would cause every symptom that's associated with the bowel distension. That's your vagus nerve, that's your parasympathetic, sympathetic, mesentery related nerve innervation. These patients have gas, distension, and also serious bowel symptoms like constipation, diarrhea, painful bowel movements. So most likely she has at least peritoneal diffuse endometriosis or some deeper endometriosis somewhere in the bowel, either rectovaginal septum or high on the right side appendix or ileocecal area could be involved.
Just to review some of the other answers that we've gotten from previous meetings, we found that associated with large cysts, constipation, bowel gas, excess fermentable sugars, refined sugars, caffeine, alcohol, processed foods, gluten, small intestinal bacterial overgrowth, and diaphragmatic dysnergia. Dietary management has been a FODMAP diet, avoiding caffeine, avoiding alcohol, avoiding processed foods, and gluten-free diets have been useful for some women. A lot of different answers on that. If you want to look that up, if you want to look those answers up on Google, just Google endobelly, ENDOBELLY. You'll get answers that may be useful, or they may be more confusing. What I'm looking for, we've got two clinical questions. I'm afraid we don't have time to discuss the clinical questions because they're too specific. The doctor still. So we've got a patient with endometriosis, and after surgery from the intestine, a hysterectomy has been suggested. She sees a neurologist for nerve issues, but after an EMRI, EMG, they still can't find out what's wrong. Could that still be related to endometriosis?
Well, most of the so-called neuropathy symptoms are not due to the nerve being directly involved, but they are referred pain. If it's around the hypogastric nerve trunk course, lateral to both promontory and deep endometriosis related in the back pararectal areas and cul-de-sac, they are mostly referred term. But I think the thing about neuropathy is the pain is usually lateral, very descriptive of the either sciatic or pudendal nerve courses are involved, and the neurologist could identify these. If the MRI doesn't show anything with respect to retroperitoneal sciatic area, usually a nodule, something is seen there. If not even seen, obviously it's worth to explore with someone who's experienced to do that. Not too many people are experienced with that. But nerve pain is distinctive. It is unilateral. It's easy. The patient complaints are very specific. Many times, 95% of the time, it's not in the nerve, it's around the nerve. It's a referred pain. Again, the disease that's around the nerve would mimic direct nerve involvement.
So, and then we'll take one last question before we leave today. Should you try to decrease the estrogen if you're using hormonal suppression and your pain is controlled? Should you try to decrease the amount of estrogen to use low dose pills like low estrin? That was part one. Part two is if suppression is controlling your pain, how long should you continue that? And should you do imaging to make sure that you don't find something on imaging that you're not finding on exam?
My take on that is if the low estrogen is working, there's absolutely no reason to change. You could stay on that, and it's actually FDA approved all the way through the end to menopause. So there's no reason to change. The reason we're treating endometriosis or managing it, as Dr. Sachkin says, is for the symptoms. You're not trying to prevent necessarily progression or to rid the disease. You're just trying to manage the symptoms. So if the symptoms are managed with low dose pill, I think that's sufficient. And there's no reason to reduce the estrogen even further. All those pills are very progesterone dominant, and they only have a little bit of estrogen in them to usually help with breakthrough bleeding. So there's no reason to change. There's no point if you have an annual exam and that exam is normal that there's no reason to do additional imaging. There's no harm in it, but there's no reason to do additional imaging.
Thank you. I'd like to thank the audience for their excellent questions and for attending our sessions, and the speakers for their very useful information. I hope that this has been a very useful and productive day for all of you. Remember that our third patient section will begin next Sunday at 9:30. This will be on complex endometriosis. I hope that all of you will be able to attend. Thank you. Have a good day.
Thank you.
Thank you.
Thank you.
See you next week.